Hi, everyone, and welcome to Community Day 2020. I'm John Scheinman, the Director of Youth Programs at the Epilepsy Foundation and your moderator for the day. I'm so glad you're able to join us. This event was organized by and for people affected by epilepsy, and we're offering it to support you and your loved ones on your epilepsy journey. Wherever you are on your journey, we want you to know that you are not alone. Today, we'll be covering a variety of topics, and you'll hear about the latest updates. You'll be hearing from both people with epilepsy and families, and also from healthcare providers. The information about all the sessions can be found in the Agenda tab. To get you used to using the chat box, please let us know where you're from. Now, I'm excited to introduce Laura Thrall to you. She is the Epilepsy Foundation's new Chief Executive Officer. Laura joined the Epilepsy Foundation 4 months ago, and as a 4-time CEO, she brings more than 30 years of leadership experience in the nonprofit sector to her new role. Welcome, Laura, and thanks for joining us today.
Thanks, John. Welcome to the 2020 Community Day. We have over 530 attendees registered for the virtual event from across the United States and 5 countries. We're thrilled to have you all here. Before my brief remarks, I want to sincerely thank the Epilepsy Foundation team who's responsible for putting together Community Day. Allison Kukla, John Scheinman, who you just heard from, Hilary Dilloff, and Tawana Lamar. I'd also like to express my sincerest thanks to our sponsors, SK Life Sciences and UCB. As John mentioned, Community Day was organized by and for people affected by epilepsy, and its purpose is to support you and your loved ones on your epilepsy journey. Wherever you are in your journey, know you are not alone. Throughout the day, you can connect with other attendees by going to the Attendee tab or visiting the exhibit hall. As John mentioned, I joined the foundation as CEO a little over 4 months ago. And one thing that has continually impressed me during my short tenure is the drive for innovation and action. The last 2 days are a perfect example of this quest for innovation. The foundation hosted its pipeline conference and Shark Tank competition. We had over 500 attendees and heard about more than 50 fascinating new devices, diagnostics, therapeutics, and innovative ways to utilize data through AI and machine learning to improve treatments. There was no shortage of innovation on display at Pipeline. So in that spirit, we used innovation and action as the theme for this year's Community Day. Innovation and action are 2 sides of the same coin in the quest to improve the lives of people with epilepsy. Innovation is how we drive improvement in quality of life and research. Action is how we embrace, enact, and embody that innovation to improve the lives of people with epilepsy. Both are key to overcoming the challenges of epilepsy and finding the best care and ultimately cures. I look forward to the event today. You'll be hearing from people and families impacted by epilepsy, healthcare providers, and other experts from the community. But most important, you'll be learning how you can get involved and take action in your community. Thank you for joining us and enjoy the day.
Thanks, Laura. We're so glad you could join us today. Before we move on, I have some reminders for you. Make sure to connect with others in the Community tab by clicking on the Attendees tab. You can visit the exhibit hall as well. It will be open all day, and we have over 20 booths that you can visit, download resources from, and where you can talk with representatives. I encourage you to take some time and explore it. Just click on the Exhibit Hall tab. During the presentations, if you have questions, please submit them using the chat box. We'll be doing Q&A at the end of the majority of the sessions and bring all the speakers on stage to answer a few questions you submitted. So use that chat box. If you're sharing information on social media, make sure to use hashtag CommunityDay2020. I would also like to take a moment to thank our Community Day sponsors. Their support is greatly appreciated. Okay, now it's time to get started. Our first session is Understanding the Epilepsies, What's Next in Epilepsy Treatment. During this session, we'll hear about Charlie's journey navigating epilepsy surgery. We'll also hear from 2 epileptologists. Dr. Ficker will teach us about seizures, their causes, and comorbidities, and Dr. French will teach us about what's next in epilepsy treatments. Now, I'd like to welcome our first speaker, Charlie Kilbourne, who, as a California state employee for 29 years, worked as a performance auditor with the Office of the Auditor General and as a legislative and policy manager with the Employment Development Department before retiring in 2017. He currently serves on the board of directors for the Epilepsy Foundation of Northern California and participates in a variety of public outreach programs provided by the foundation, including seizure first aid trainings. Welcome, Charlie, and thanks for joining us today.
Good morning, John, and thank you. Good morning, everybody. I'm Charlie Kilbourne. I'm a board member with the Epilepsy Foundation of Northern California and a person living with epilepsy. I want to thank the foundation for making this virtual conference possible after it was canceled back in March, so I look forward to the day. So I was asked to talk about my journey with epilepsy and what took me to my ultimate situation where I am today. So I'll give you a little bit of the background and where I am today. I was first diagnosed with epilepsy at age 5 in 1960. My seizures changed over the years, creating new challenges along the way, and I was treated with 8 different medications during the first 40 years following my diagnosis. After experiencing breakthrough seizures in the mid-1990s, I attended a workshop discussing surgical alternatives for epilepsy patients that was sponsored by the Epilepsy Foundation of Northern California and the University of California, San Francisco Comprehensive Epilepsy Center. I underwent a right temporal lobectomy in 1999 at UCSF, and next month I will be seizure-free for 20 years. So that's where I am today, but the detailed journey of the first 40 years is this. I was diagnosed at age 5 with tonic-clonic seizures, and I developed a pattern of simple partial seizures or focal aware seizures. They were infrequent, generally monthly, but they were consistent. I was fully conscious. I had left side shaking, speech impairment, and they were always preceded by an aura or a warning in the preictal stage. They could last for seconds or a few minutes. My mother was my main caregiver, and she was very good at ensuring that I had my medication, but she really wasn't an advocate for me. She listened to the doctor. She obediently answered his questions, but didn't ask questions because you just didn't have those conversations in the 60s. Well, we still have that problem in the 21st century, unfortunately. She described my seizures as petit mal, which are absent seizures today, which are actually generalized seizures. So it's very possible and probable that I had both partial seizures and generalized seizures because my elementary school teachers said that I didn't pay attention in class and I daydreamed. But I was able to participate in all activities and I enjoyed a full social life. I learned the importance, though, of finding my own voice and being able to explain epilepsy to other people. During high school and college, my seizures were under good control with medications, but I did identify the main triggers when I had seizures, such as stress, anxiety, and lack of sleep. In my late 20s, I experienced clusters of focal aware seizures with an aura. My neurologist kept changing my medications and altering doses with some periods of success, but not total control. Then came the breaking point in my late 30s. I experienced several breakthrough complex partial seizures, or focal impaired seizures now. My wife witnessed me walking throughout the house, fully conscious, but unaware of my surroundings. I had no aura preceding these seizures and no recollection of the events afterwards. I experienced a number of events over 4 years occurring at home, at work, at church, and at my van pool. And this resulted in a number of ER visits. I felt my neurologist was playing Russian roulette with my medications, switching me between 5 different medications and combining up to 3 at a time and constantly changing the doses. My frustration was compounded by having to taper off medications while I started new ones. So the side effects were oftentimes debilitating. I experienced extreme fatigue, a loss of equilibrium, and that was almost as discomforting as not knowing if and when the next seizure was going to happen. So I was not confident in my neurologist was able to discuss alternatives beyond medication. So as I mentioned earlier, my wife and I attended a lecture on surgical alternatives for epilepsy patients in 1997. co-sponsored by Epilepsy Foundation Northern California and UCSF. I give seizure first aid trainings today, and I say in my lecture as I introduce myself that the 5 minutes I spent with the epileptologist after that lecture and listening to the lecture was more valuable and informative to me than my 30 years with my 30 previous years with the neurologists. This was the first time that I was told that if you fail 2 or more medications, you may have intractable seizures and should consider more aggressive alternatives if you're seeking total control. At that time, I was on my 7th medication. So the decision point there was that I needed to be referred to UCSF for surgical consultation. At UCSF, the doctors reviewed my seizure history, my neurology assessments, MRIs, EEGs, and they performed several tests to determine if I was a good surgical candidate. First, I underwent neuropsychological testing, which tested my memory, my aptitude, and mental fitness for surgery, and this was repeated post-surgery as well. They conducted their own MRI, PET scan, and the most important, I felt, was the video telemetry that they did, which was an inpatient procedure where over a few days they took me into the hospital, wired me for EEG analysis, reduced my medications, and let me have seizures on a video camera. They collected a wealth of information because I gave them a lot of seizures. And the final test was the WADA test in preparation for surgery. They placed a catheter in my femoral artery in my leg, moved it up to my brain, and they gassed each side of the brain, putting it to sleep so they could test to see how my senses were affected and to determine if I could undergo surgery under a general anesthetic. The doctors found I was a good candidate for surgery. They were able to isolate and resect the lesion on my right temporal lobe that was causing the seizures. And they determined the lesion was a result of a high fever from mumps encephalitis that I experienced at 6 months old. Most people never learn the cause of their seizures, so this answered a 40-year question for me. So from surgery in 1999 at age 43, I experienced a few seizures post-surgery, and I had 2 nocturnal focal impaired seizures over the next year and a half. But after the second, an extended focal impaired seizure that lasted a half an hour in September of 2000, my doctor switched me to a new medication, and as I said earlier, next month I will be seizure-free for 20 years. My 60-year journey with epilepsy has taught me to find my own voice and to be my own best advocate. If you're a parent or a caregiver of a person with epilepsy, it's important that you be an advocate for them as well, providing as much information to the patient and the doctor about what you witness when they have seizures. You have the right and the responsibility as a patient and a caregiver to ask questions of the doctor and seek the best outcomes. If you do not feel you're receiving the best possible care, seek a second opinion or consider an assessment with an epileptologist at a comprehensive epilepsy center if one is available to you. Thank you and enjoy your day.
Thanks, Charlie. We really appreciate you being here today, and congratulations on being 20 years seizure-free. I'd like to welcome our next speakers, Dr. Dave Ficker and Dr. Jackie French. Dr. Ficker is a neurologist with the Epilepsy Center at the UC Gardner Neuroscience Institute and has been a neurologist with UC Health since 1997. He is also the chair of the Epilepsy Foundation Professional Advisory Board. He will speak first, and Dr. French is the Chief Medical and Innovation Officer of the Epilepsy Foundation and a professor of neurology in the Comprehensive Epilepsy Center at NYU Langone School of Medicine and founder and director of the Epilepsy Study Consortium. She will speak second. For this session, if you have questions for them, please put them in the chat box so they can be answered. Let's start with Dr. Ficker. Welcome, sir.
Thank you, John. And I want to thank Charlie for sharing his story about his epilepsy journey. I'm glad that we have so many people from across the country and across the world participating in today's Community Day. And this is my first involvement with Community Day, and I want to thank the Epilepsy Foundation for allowing me to be involved. I was given the task of introducing epilepsy and providing sort of the epilepsy 101, so to speak, to provide a basis of making sure we all understand what epilepsy is, what the causes are, and what other potential things may be associated with epilepsy. Some of this may be old information to you, but some of you may be just starting your journey with epilepsy, and I'm hopeful that you will take something away from this that will help you better understand your epilepsy or your loved one's epilepsy. So we're going to start with the very basic question, what is epilepsy? And actually there is some new information here and a new definition of epilepsy that was put forth about 3 to 4 years ago. Previously, we would define epilepsy as an individual would have epilepsy if they've had 2 or more seizures. So you would have to wait for that second seizure to be diagnosed with epilepsy. But over the many years, we realized that this was not a practical definition. We would often see an individual who had a single seizure, and upon their evaluation, we would determine that they may be at a higher risk of a second seizure, and we would then consider treating with an anti-epileptic medication at that time. So we would oftentimes treat people even if they didn't meet the old definition of epilepsy. So the new definition of epilepsy, it still has that 2 or more seizures, 2 or more unprovoked seizures, but you can also have a single seizure plus some evidence on the evaluation for a potential increased risk of having another seizure. That may include an abnormality on your EEG or an abnormality on your MRI or the presence of other risk factors. And one of those could be you have a single seizure and an underlying genetic condition, for example, that might put you at increased risk for seizures. So we've taken that new definition as well because it really sort of matches what we practically do in the clinic. And over the years, the term epilepsy and seizure disorder is intertwined. Those are really the same thing. This is just an example of a patient that I had seen who presented with a new onset, a young lady in her 40s actually, presented with her first generalized tonic-clonic seizure. She was running a marathon. No other seizures, no other risk factors for seizures. But her EEG shows a brief burst of generalized spike wave. And so she met that definition of a single seizure plus an abnormal EEG. So we determined to treat her, or made the decision that to put her on an anti-epileptic drug, given the fact that her EEG was abnormal, putting her at a much higher risk of having a second seizure. And she's done well with that anti-epileptic drug and has been seizure-free. The other thing to consider is that epilepsy is really a term that just describes that the individual is at risk for recurrent seizures. It doesn't tell us anything about the cause. It doesn't tell us anything about the prognosis or the outcome or the predicted outcome. And there are many, many, many different types of epilepsies with many different types of outcomes. One example may be if you look at juvenile absence epilepsy versus Lennox-Gastaut syndrome. Both are epilepsies, but they are distinctly different. Juvenile absence epilepsy is a condition where individuals have staring seizures that they outgrow, that after a certain age, typically by adolescence, that individual's seizures go away. They're able to come off medication and remain seizure-free for the rest of their life. Lennox-Gastaut syndrome is distinctly different. EEG patterns may be somewhat similar to juvenile absence epilepsy, but Lennox-Gastaut syndrome is oftentimes associated with very difficult and frequent seizures, different seizure types, including drop seizures, associated developmental delay, and a lifelong condition. Much, much different. So just 2 stark contrasts of 2 different types of epilepsies. So when we describe epilepsy or we diagnose epilepsy, we like to dig a little bit deeper and try to determine, is there a syndrome or an epilepsy syndrome that we can identify? Because that really helps us determine treatment and really helps us counsel patients and families on prognosis. There are 2 very broad categories of epilepsy: focal onset epilepsy and generalized onset epilepsy. As Charlie mentioned previously, he had focal epilepsy. His seizures were found to arise from the right temporal region. So his seizures are focal onset. We also use the term partial onset seizures as well. Generalized onset epilepsies have seizures that don't start focally in one part of the brain, but start in all areas of the brain. and the EEG patterns are distinctly different. And I'll show you a couple of examples of EEGs shortly. One very common misperception in the lay community is that epilepsy is a condition that starts only in childhood. Epilepsy is very common. There are approximately 3 million Americans who live with epilepsy currently. And the data suggests that one in every 26 individuals has a chance of developing epilepsy sometime in their lifetime. So a very common neurologic condition, very, very common. We see up to 70 to 130,000 new cases in the United States who have new onset epilepsy, and it affects all age groups. The graph shows you the age of onset of epilepsy, and you can see that there are two peaks. There's a peak in childhood, but also a peak incidence or age of onset in the elderly. But that line never goes to zero. So there is always a potential for developing epilepsy at any age, at any time. The second question is what causes epilepsy? And unfortunately, about 70% of the time, we cannot identify the underlying cause of the epilepsy. That's even with good MRI techniques, good EEG techniques. But only about 30% of the time can we identify the cause of the epilepsy. In general, and it's not a guarantee, but those individuals that have an unknown cause may have a better prognosis. Their seizures may be more likely to be controlled with medications. The graph shows you a number of different types of or causes of epilepsy, and these are categorized into things like vascular, a prior stroke, or a blood vessel abnormality in the brain, congenital abnormalities, a developmental abnormality in the brain, brain trauma, brain tumors, prior history of brain infections, like in Charlie's case, he had encephalitis, which caused an abnormality in the brain. But again, most of the time, the causes are unknown. Now, in a little bit, you'll hear about genetics in epilepsy, and as our techniques for analyzing the genetics of an individual, we might see that our causes of epilepsy, we may be able to identify an underlying genetic cause in some individuals with epilepsy. So these numbers may change, 10, 15 years from now. How do we diagnose epilepsy? One thing to recognize is there is not a single diagnostic test for epilepsy. There's not one test that we do that will say you have epilepsy. Really, the best tool we have is actually getting a good history from the individual and from witnesses and family members regarding the seizures, what happens during the seizure, are there other seizures? It's not uncommon that we will see an individual who presents with their first generalized tonic-clonic seizure, and when we do a detailed history, we find that they may have had staring episodes or daydreaming episodes previously. And so that individual that seizure that led to medical attention may not have been their very first seizure. We do a neurologic exam, but at least in the adult world that I treat, generally is not very helpful, although sometimes you might see some subtle abnormalities that might help you. But we do rely on diagnostic testing. The two we really rely on are EEG testing and MRI. We'll talk a little bit about those in a bit. There are some additional advanced techniques that are often available at epilepsy centers. Those include ambulatory EEG, where you wear the EEG at home, typically for 1 to 2 days or so. There is inpatient video EEG monitoring, where, as Charlie was describing, he was brought into the hospital to record seizures. We'll talk a little bit about that in a moment. There we go. So on the EEG, we are looking for what are called epileptiform abnormalities, also called spikes or sharp waves or spike wave discharges. These are very brief abnormalities that indicate that part or parts of the brain are potentially prone to producing seizures. A seizure occurs when there's abnormal electrical activity in part or parts of the brain. The EEG is trying to look for evidence of that electrical abnormality outside of seizures or in between seizures. We call it an interictal or a between seizure test. But unfortunately, it's not a perfect test. A single normal EEG can be seen in roughly at least 50% of patients who do have epilepsy. So if we're really looking for an abnormality to help us make that determination, we may repeat the EEG, or we might do a longer EEG, an ambulatory EEG. The EEG can help us determine if the patient has focal onset seizures or generalized onset seizures. And then Charlie mentioned his experience with video EEG monitoring. This is a longer, more advanced EEG where we record EEG around the clock, 24-hour continuous EEG. We also record video. And our goal on this study is to record seizures. We typically will reduce medications or stop seizure medications and wait for seizures. We record the seizure. We see what the EEG shows at the time of seizure. We also learn a lot from the video recording as well. This will tell us the type of seizure an individual is having. Indications for this include if somebody has refractory or difficult to control seizures and is being evaluated for epilepsy surgery, we need to record seizures and pinpoint the region of the brain where seizures arise from. It may help us determine the type of seizure someone has, whether that's an epileptic seizure or a non-epileptic seizure. Or it may help us determine, does the patient have focal onset or generalized onset seizures? It may help us tailor the patient's medication treatment to best control their seizures. And this is typically done in patients whose seizures are not well controlled. The typical, and I think Jackie's going to talk a little bit about treatment in a moment, but we start with an anti-epileptic drug. If that individual is not controlled with a medication, we try a second medication. If that medication doesn't work, then we consider video EEG monitoring to really get us more information and more detail about that individual seizure type and help us tailor treatment. Here is an example of a patient who has focal onset epilepsy. This is a focal spike that's arising from the right temporal region. I can't point that out on the screen with my pointer, I don't believe, but the abnormality is this very brief, less than a half a second electrical discharge that indicates that that's likely the part of the brain where that patient's seizures come from. If we contrast that to this EEG, this shows a generalized spike wave discharge. So you can see this burst of abnormalities here. There's a spike and slow wave, and this is occurring from both sides of the brain. This is an individual that turned out to have juvenile myoclonic epilepsy, much different than right temporal lobe epilepsy, and the treatment is distinctly different. The other major test that we do is an MRI. This is an imaging study that uses magnetic waves to basically produce an image of the brain. Many patients who go to the emergency room with new onset seizures may get a CAT scan of the brain, which is an X-ray type picture of the brain, but an MRI shows us much more structural detail. That may help us identify the underlying cause of a seizure. Examples that we may look for include scar tissue or if someone has, the fancy term is encephalomalacia from brain injury, for example, or the example I'll show you next is a mesiotemporal sclerosis, a very small area of scar tissue that it may be caused from underlying febrile seizures or encephalitis, like Charlie described. We are also looking for tumors of the brain. These could be, in some instances, malignant brain tumors, but very commonly more low-grade tumors or benign tumors. We may see vascular lesions, whether that's a small entanglement of blood vessels, and developmental abnormalities. If there's a small abnormality in the way the brain developed, oftentimes that may be silent and may be the reason for the seizures. But we also have to recognize, like EEG, the MRI is often normal as well, and it doesn't rule out epilepsy. So this is an example of an individual that has a small area of scar tissue in the left temporal region, specifically in the left mesiotemporal region. And when this patient underwent surgery for seizure control under the microscope, this was found to be what's called mesiotemporal sclerosis, or essentially scar tissue in that temporal region. I want to move on and talk a little bit about comorbidities in epilepsy. And this is a very hot topic and has been so over the past few years in the epilepsy arena. A comorbidity is defined as the presence of one or more additional disorders that co-occur with a primary condition. So the individual may have epilepsy, but they may have something else that is commonly occurring, that commonly occurs with epilepsy. We'll give you some examples in a moment. The data suggests that if that comorbidity is not recognized or not treated, overall there may be poor health outcomes. One example includes depression in people with epilepsy. If it's present and untreated, it may be associated with a poor quality of life when you look specifically at quality of life measures. So just some examples of comorbidities in epilepsy. Mood disorders are probably one of the more common comorbidities that we see, both depression and anxiety. In general, this is a study from Canada where they looked at a population of people with epilepsy and also the general population and determined the frequency of mood disorders. And roughly the presence of any type of mood disorder sometime in the life was roughly double that of those that did not have epilepsy. So roughly 25% of patients have a lifetime risk of, there's a 25% risk of a mood disorder sometime in an individual's life. And if you look in the previous 12 months, about 14% of patients had a mood disorder. Suicidal ideation was also more common in people with epilepsy, and the presence of any type of mental health disorder was seen in about 1/3 of patients. And so as neurologists and epileptologists, we have been screening patients for epilepsy with some simple tools and even treating patients who have coexisting epilepsy with depression or anxiety. Some of our current treatments, the SSRI, the antidepressant medications, are very effective and can be taken safely in most cases. So we are screening and trying to address this in our epilepsy clinics. Other common comorbidities include sleep disorders. And there are some data to suggest that the presence of obstructive sleep apnea that's untreated may be associated with more difficult to control seizures. And if that sleep apnea is treated, seizure frequency may improve. We know that certain, particularly older anti-epileptic drugs may be associated with the greater risk of developing osteopenia or osteoporosis. So we are screening our patients, selected patients for bone disorders. Migraine is a very common comorbidity in patients with epilepsy. And interestingly, some of our seizure medicines are also used as migraine preventative medication agents. Memory problems are very common, particularly in people with difficult to control seizures. And that is most likely related to the underlying seizure disorder or the underlying cause, but sometimes our treatments may be associated with cognitive side effects. So we have a high, sort of our antennas are up for screening and looking for memory problems as well. And particularly in the pediatric population, you can see attention deficit disorder, learning disabilities, and autism much more frequently in epilepsy than you can see in the general population. So these are not all the comorbidities we see, but just selected examples. So to conclude, some take-home points that I'd like to make. One is that epilepsy is very common. 1 in 26 will develop epilepsy sometime in their lifetime. And again, that's a number that I think is not well understood by the general population in the lay public. Most causes of epilepsy are unknown. About 2 out of 3 cases, we can identify the causes of epilepsy. It's important to understand the difference between focal and generalized onset seizures and epilepsies because that may impact treatment choice. And comorbidities are very common and must be screened for and addressed along with seizure control to get the best outcomes in our patients with epilepsy. Thank you.
Hi, welcome everybody. It's fabulous to be here, and I wish I could see all of you, and I hope that next time we're all going to be in person. But until then, I'm going to tell you a little bit this morning about seizure medication and how it gets picked and how it gets approved by the Food and Drug Administration. So we're going to get started, and I think that Dr. Ficker actually set this up very nicely for us to understand how new seizure medicines are selected for you by your doctor. These are my disclosures. I work with a lot of companies that are developing new therapies so that we can speed them to people who need them. And there are a lot of very interested companies. If any of you were at the pipeline meeting for the last 2 days, you would have seen some very exciting and interesting new therapies in the works. So let's just start out by talking about what you can expect from drug therapy. there were 2 studies that were done in clinics that were for people with newly diagnosed epilepsy in the same clinic. One of them was done in 2000 and one was done in 2012. And they looked at over time how many people could become seizure-free with medication. So when they looked at how many people got seizure-free with the very first drug that a doctor picked for them, monotherapy means the drug is used alone, about half of people got seizure-free. When that didn't work and another drug was tried, an additional 13% could become seizure-free. If 2 drugs didn't work, unfortunately, the likelihood that a third drug would work got very, very low, 1%. And even when people tried all different medicines and all different combinations, only additional 3% became seizure-free. So over the time that these individuals were followed, when you look at the population of people with epilepsy, no matter what kind, only 6% became seizure-free with medication. The other, unfortunately, either required surgery or were what we call treatment resistant, meaning that medication was going to get their seizures under control. They went back and did the same study in 2012, and unfortunately, despite the fact that there were over a dozen new therapies that were approved by the FDA between 2000 and 2012, there was only a 4% difference. So only 68% now were becoming seizure-free compared to 64% in 2000. So that's not good enough as far as we're concerned. That doesn't mean people weren't made better by the new drugs that were approved. Certainly they were, but we are looking for that brass ring of seizure freedom. We're really expecting that from our medications. So do we need more anti-epileptic drugs? I already discussed with you the problem with the current drugs is that about 40% are going to be resistant to those drugs and not get control, and that over the last 20 years, that 40% has not changed to a great degree. And in addition to that, even though 60% approximately, or 2/3 of people do become seizure-free with drugs, that some of them are actually not very happy seizure-free on the drugs because they're having side effects or safety issues or issues with getting pregnant. And we need better drugs, not only to get that 1/3 of people to 40% of people seizure-free, but also to improve side effects. And people are working on both of those things, I can promise you. I want to take 1 minute to talk about some interesting news from the epilepsy front, and that is the International League Against Epilepsy is considering changing the official name of the anti-epileptic drug. So I'm sure you've heard it called anti-epileptic drug for a very, very, very long time, but actually you may start to hear people talk about these not as AEDs or anti-epileptic drugs, but as anti-seizure medicines, which will be ASM. Why are we changing the name? This is to highlight that actually we shouldn't call it anti-epilepsy because it is a symptomatic therapy in most cases. Just like you take a cough drop for a cough, you take an anti-seizure medicine for a seizure, but it does not actually reduce the tendency towards epilepsy that underlies it. The reason we think it's important to point that out now is because, in fact, there are companies that are working on anti-epileptic drugs, drugs that will actually fix what's wrong underlying rather than just treating the symptom of seizure. And that in and of itself is super exciting. So I'm going to go back a little bit to what Ficker said, because this is very important in understanding how drugs are approved and for what. So you heard from Dr. Ficker that many people have what's called focal epilepsy, which means that seizures start in a single part of the brain, and other people have generalized epilepsy. Let me go back to that. Other people have generalized epilepsy, where it starts everywhere at once. And then there are a group of people who have both generalized and focal epilepsy, a combination, and usually those people who have something like Lennox-Gastaut syndrome or Dravet syndrome also have some problems with the overall brain, or what we call an epileptic encephalopathy. When you're looking at how people get treated right now, as I said before, usually the doctor will start with a single drug. If that doesn't work, they may try another single drug, or they may go on to combine drugs. And many people who have treatment-resistant epilepsy are actually on 2, 3, or 4 drugs. And they comprise the people we would call drug-resistant epilepsy. And if one has drug-resistant epilepsy, there are other things that can be done other than new medications. I just want to very briefly say, for children primarily, there is the ketogenic diet, which can be used. People can have implantable devices, such as the vagus nerve stimulator, or a brain implanted device, such as the responsive neurostimulator, or RNS, or the deep brain stimulator, DBS. So those have to be put in with the surgery. You've already heard a little bit about if you have focal epilepsy and the part of the brain that has the seizure abnormality can be discovered, then you can have that removed and surgery can be performed. So both the RNS and the surgical intervention, and also a laser ablation, which is a less invasive type of surgery where instead of cutting the head open, you actually put in a laser and burn out the seizure focus. Those 3 things would need you to have focal epilepsy to know where the seizures are coming from in order for it to work. Whereas the other things, the ketogenic diet, the vagus nerve stimulator, and new medications actually can work no matter whether you have focal epilepsy, generalized epilepsy, or combined focal and generalized epilepsy. So how are anti-seizure medicines approved by the FDA? They are actually tested in and approved for specific seizure types within epilepsy syndromes. So, for example, you might get an approval for focal seizures occurring in focal epilepsy. So focal seizures don't only occur in focal epilepsy, but the approval is very specific for the situation in which they occur. Or you might get an approval for myoclonic seizures in juvenile myoclonic epilepsy, for example, or drop seizures in children with Lennox-Gastaut syndrome, which is a combined focal and generalized epilepsy. So the approvals are quite specific, although once a drug is approved, when it's been tested in a certain syndrome with a certain seizure type, it is not uncommon for doctors to try it in different seizure types and eventually start using it more broadly, even if there is not an FDA, a Food and Drug Administration indication for doing so. So when you look at the drugs that have been approved since 2012 to 2020, I've subdivided them here into the ones that the indication in red was focal, and the ones where the indication is written here in blue, which is either for generalized epilepsy and certain seizure types, or what we call combined focal and generalized epilepsy. So for example, perampanel or Fycompa was approved in 2012 for focal seizures, and then in 2015, it got an additional indication for primary generalized tonic-clonic seizures in generalized epilepsy. S like carbazepine and brivaracetam are approved for focal seizures. Everolimus is a very interesting drug, or Afinitor, which was approved for seizures associated with tuberous sclerosis, and it actually may be an anti-epilepsy drug because it does work on the underlying cause of seizures in the brain. And many of you are familiar with Cannabidiol or Epidiolex. In 2018, it was approved for seizures associated with Dravet syndrome and drop seizures in Lennox-Gastaut syndrome, and just this year in 2020, it was approved for seizures associated with tuberous sclerosis. Another exciting approval in 2020 was fenfluramine or Fintepla for Dravet syndrome. And one I'm going to just talk a little bit more about, cenobamate or Xcopri, which was approved in 2020 for focal seizures. So the thing that's very interesting about cenobamate, and it was just approved a couple months ago, so we'll have to see how things go in the clinic. But in clinical trials, 18% of people who were placed on the highest dose were free of seizures during the treatment period. So that paradigm that I showed you before, saying that no new drug had increased the amount of treatment-resistant people who were becoming seizure-free. Certainly in clinical trials, cenobamate did, and that even led some people to call it a game changer. So there were studies, there were papers that were written saying cenobamate is a new hope for treatment-resistant epilepsy. And a game changer for focal seizures, because this is the first drug that we've seen that actually seems to take a chunk of people who are in that treatment-resistant group, who you would only expect 1% of them to become seizure-free with new drugs. And again, 18% became seizure-free in the trials. And we'll wait and see what happens. There are other new therapies in the pipeline for focal epilepsies, such as natalizumab from Biogen, CVL-865 from Cerevel, and Xenon 1101 from Xenon. And if you had been at the meeting the last couple of days, you would have heard some very interesting new updates on these three drugs that are in development. And we have a new way of thinking about these resistant focal seizures. So we're starting to wonder whether epilepsies that are in that 1/3 of not responding to drugs are really the same underlying as those that do respond. And so there is a big attempt to make new animal models that reflect that particular group of people, with goals of creating drugs, not for everybody with focal epilepsy, but for people, let's say, with treatment-resistant focal epilepsy, for example. One word on other approvals that have come recently, which are rescue therapies. So what is a rescue therapy? A rescue therapy is a treatment that's not given every day, that can be used to either rapidly stop a cluster of seizures right when it happens, or treat when the risk of seizure is higher than usual. So it's kind of like an EpiPen for seizures. And many people can benefit from having a rescue therapy available. And there are several that have been recently approved, Nasolam, nasal midazolam, which, as you can see, is something that's put in the nose, nasal diazepam called Plumiaz, and buccal clobazam or Sympazam, which is a little film that you can put in your mouth. And all of these work in about 10 minutes. And under development is inhaled alprazolam. This is sort of like an inhaler for epilepsy, and it may work even faster in 2 minutes or less. So that one is still in development, and we'll see how that one goes. So in conclusion, much is new in the epilepsy field. There is much more to come in the pipeline, and hopefully all of these therapies and more, and the ones we've been hearing about for the last 2 days, will not only be anti-seizure medicines, but anti-epilepsy drugs in the true sense, and will lead to better quality of life, less side effects, less comorbidities for people with epilepsy. Thank you so much.
Thanks, Dr. Ficker and Dr. French, for your wonderful presentations. I have to say, as a member of the epilepsy community, it's always good to see what new treatments are coming up and to have additional options. So remember, if you have questions for them, please add them to the chat box and they will continue to answer them. Well, now that we've heard about the epilepsies and epilepsy treatments, we want to hear from you. We're launching a poll with 3 questions about epilepsy treatment options. If you scroll up just a bit from the live video, you can find the link for the poll. Please take a few minutes to answer the questions for us and choose the one answer for each question that is most applicable to you. We'd like to have as many of these answers as possible, and we really appreciate your taking the poll. As you're answering the questions, I want to give a special thanks to our pollster, SK Life Science. We really appreciate that support. And while you're with us today, don't forget to visit the exhibit hall, which you can find by clicking the exhibit hall tab. And also make sure that you go into the attendees tab, because you can also join and talk to other attendees at the conference. Okay, now it's time for our next session, Genes and Epilepsy, Understanding the Basics. During this session, we'll hear about Shannon's journey with epilepsy and genetic testing. We'll also learn about how to use results of genetic testing from Dr. Wirrell, and Kim will share her family's journey with epilepsy and share the work of the TESS Research Foundation. It will be followed with Q&A, so please make sure to submit the questions in the chat as we go. And now I would like to welcome our first speaker, Shannon Abdul Wahab, who is the Executive Director of the Epilepsy Foundation, Orange County. She comes to you with a long history in the field of epilepsy, as she was diagnosed with a genetic form of epilepsy at the age of 4 and has survived hundreds of absence, myoclonic, and tonic-clonic seizures since then. But I will let her tell her story with you. And so welcome, Shannon. It's great to have you here today.
Thank you. Thanks, John. And hi, everybody. I'm so happy to be here today. As John said, my name is Shannon Abdul Wahab. I'm the Executive Director for the Epilepsy Foundation in Orange County. I actually live in Long Beach. And anyway, I just wanted to share a little bit, about myself. I'm going to go back one screen. My apologies. So my journey started a long time ago, and it actually started when I was about 2 years old, and my parents noticed I was having seizures when I was 4. And I was having absence seizures, and I was taken to the doctor, and I was just diagnosed with epilepsy. And mind you, this was 42 years ago, but I was just diagnosed with epilepsy. That's what I was given, and nothing genetic, no specific epilepsy. Nothing like that. So, and that was my diagnosis, epilepsy as a result of a fall where I bumped my head. Done. I was put on medicine and moved forward with that. And later, it was actually, I was having absence seizures, and then I had my first tonic-clonic seizure at the age of 10. And I'm going to kind of scroll forwards and backwards a little bit with my slides here, because I want you to see. So this is kind of my timeline. Age 4 to 10, I was having all absence seizures. My first tonic-clonic seizure was at age 10. Age 16, I noticed that I was having these funny jerking movements. And the only reason that I noticed, I was hanging out with my boyfriend when I was 16, and he actually was like, "You're sure jerking a lot." And I said, "I know, I've been doing that a lot lately. I don't know what's going on." And he's like, "It's just what people do when their bodies relax." And so I took the word of a 16-year-old boy and went with it. And that was that. So age 17 to 25, I continue having all 3 of those types of seizures. I was seeing a neurologist in the Bay Area. 25, I was in San Francisco, and I, had some more seizures, I was having really bad tonic-clonic seizures actually at the time. So that probably took, over everything, because those for me were so much worse. So I wasn't as concerned about anything else that was going on. But then I saw an epileptologist who then, diagnosed me with JME, which is what I'm kind of here to talk to you about today, which is called juvenile myoclonic epilepsy. I was not given any information about JME. I was 25. I didn't really take the time to look it up or see exactly what it was. And I didn't know that it was genetic. I wasn't told that it was genetic. At the time, I think it was still a little bit uncertain. I mean, we're talking now like 20 years ago. But my diagnosis wasn't completely confirmed until probably, I think, 8 years ago. And when I came to the Epilepsy Foundation in Los Angeles, I met with the then president, Susan Peach Escueta, whose husband does a lot of research at UCLA, specifically in JME. And that's really why it was confirmed for me. And which is also why I'm here to talk to you today. So I'm going to back up now and tell you a little bit more, one more item going back, a little bit about JME. So JME stands for Juvenile Myoclonic Epilepsy, and it has that name because, number one, it typically is onset in your adolescence, typically, but it's characterized by myoclonic jerks, quick movements, arms and legs, almost a twitching movement, something to that nature, and can be misinterpreted for just, which is unfortunate, obviously. So, but it also can be characterized by generalized tonic-clonic seizures as well as absence seizures. So JME is called an idiopathic primary generalized epilepsy syndrome. Essentially what that means, what the idiopathic part of that means, it's that believed to have a strong underlying genetic basis. So seizure, for people with JME, often occur when they first wake up in the morning, but not always. And they're triggered, like many other seizures, by lack of sleep, fatigue, stress, alcohol consumption, and so on and so forth. And patients with JME usually require lifelong treatment. With the treatment of the AEDs, the overall prognosis is good. So, which is great and fantastic, and something again that I'm here to talk to you about today, because the overall prognosis is pretty good. It is sometimes, as it was for me, it can be missed. So the just to kind of 1 in 1,000 people with epilepsy will have JME, and JME makes up 5% of the population of people with epilepsy. So it's fairly common, but then slightly missed. So just a few things. So with juvenile myoclonic epilepsy, that if people are going to have absence seizures, they are typically the first seizures, and that's such the case with me, followed by later on, even a couple years down the road, the myoclonic jerks. For some individuals, for about 17% of the population of people with JME, myoclonic jerks is all they're ever going to have. And a lot of times those jerks are unilateral, meaning they're just on one side of the body, which is the case for me. I will be, like holding my glasses, and all of a sudden I'll have a jerk and they'll literally fly out of my hands. So, but I would take that any day over a tonic-clonic seizure. So I'm okay with that. And then usually if somebody's going to have the tonic-clonic seizures, they will appear a few months after the first on the onset of the myoclonic seizures. So that's kind of the background of those. And they're, like I said, they're genetically determined. 50% of families with JME report seizures in a direct relative or cousin, aunt, or somebody of that nature. And the reason it's JME is it's very complex and not completely understood. So when I say complex, and when we're talking genetic, what that means is there's mutations there from one of several genes. So it makes it a little bit more difficult for the geneticists, the doctors, to really kind of nail everything down. And so ideally is to have a family like mine where there are a lot of people with JME in one family. And that, that's really helpful to them, and they can really, begin to understand what's going on. But the part that's slightly tricky is that a negative result, even with JME, does not completely rule out the possibility of a genetic diagnosis. So that's, maybe later on, it's kind of a tough, anything with genetics can be a little bit of tough. So while JME is an inherited disorder, and as I about a third of the patients have a family history, but the exact mode of the inheritance is not clear. So studies have indicated that inheritance, like the people who inherit the gene or the genes associated with JME sometimes do not even develop symptoms. And so this is why JME is tough. And this is why I'm here again to talk to you today. I mean, to share a little bit of my story with you. So I'm going to just move forward. And this is what I want you to understand. So we went through my timeline. And so this is my family. And the top in the middle, this is my dad. And he's holding me and my brother. And if you look to the right, that's me again. I'm Shannon, the daughter, and I have epilepsy. I'm married to Andy. Andy does not have epilepsy. And then if you go to the left, you see my brother. His name is Ken. Ken is married to Ryan. And Ken and Ryan do not have epilepsy. And it's important to note also, Ken has never been tested to find out whether or not he has the gene for epilepsy. And that would be something that I would be interested in finding out. So my dad, yes, for epilepsy. My dad has myoclonic jerks. My dad has had the myoclonic jerks as long as we can remember. We all thought it was funny. We're kind of laughing, a little here and there. When he drives, especially, is when it happens. It's on the right side of his body. And we didn't realize what it was until I was specifically diagnosed with JME at the age of 37. And then it all kind of happened for us. So my dad has JME. There's nothing on my mom's side of the family, as far as we know. And then if you see, my brother has 3 sons. The oldest is Reed on the left. The middle is Miles, and the youngest is Wyatt. Wyatt was diagnosed with JME 7 years ago, and he has all kinds of seizures, controlled, and takes the same medicine that I do, which is Depakote. Miles, my middle nephew, started having myoclonic jerks about 3 months ago, and this is very, very important. His mom is a nurse. It runs in our family. It's genetic. We know it's genetic. I do what I do. I'm, here working for the Epilepsy Foundation. She took him to the pediatrician, noticed right away he's having the jerks. She knows the jerks could be followed by tonic-clonic seizures. And she knows that her other son and her sister-in-law both have tonic-clonic seizures. She took him to the pediatrician. The pediatrician said, it's just a twitch. The pediatrician would not give her a referral to see the epileptologist, which is tragic. I can't even, I said, you need to go back to that pediatrician and you need to say, my son is 16, he's driving, and you need to make her understand, like, this is the next step. It has shown to be the case in our family. And if he has a seizure while he's driving, whose shoulders is that on? And so she is in the process of still getting that referral, which is, it's mind-boggling. But that's where she's at, and she's doing it. And I think that's why it's so important to understand about genetics, and to understand what happens, to explain this is what's going on in my family, and this is what is next. And although it's devastating, and I don't wish it on Brent or anybody, this is how it has worked for us. And you know, for my child who's driving, if I see those, you know, and it's just a little tiny jerk or twitch, I need to be on it. And you know, and so she's on it, and she's getting it done, and she's getting it handled, and that's wonderful. So, but I just think that portion is very, it's scary to me. And it should be scary to everybody. This is now, I just kind of an easier way to break it down. So this is my family. So this is me and my brother and my dad at the top. Again, I have epilepsy. Larry's daughter has epilepsy. Larry's son does not. Larry's son has not been tested. Larry's 2 grandsons do have epilepsy. My 2 children, I have 3 children. My 2 biological children do not have epilepsy and have been tested and do not carry the gene. However, as we learned before, this does not mean that they will not develop seizures in their lifetime, or that their kids will not have seizures and will not have epilepsy. And then my 3rd is adopted from Africa. So she's got a whole slate of issues of her own, but epilepsy is not one of them. So having said all of this, this is just I really just wanted to show you how it works and how it's passed. And, you know, the fact that for me, I didn't even know until I was 37 that this was a genetic disease. For me, I mean, that this type of epilepsy was genetic, today is mind-boggling. And, you know, it probably could have saved our whole family a lot of trauma and issues along the way, had I been told. And mind you, we're doing a lot of research, and there's more and more research going on. But I didn't know. I didn't even know that it was a possibility. And again, like I said, this is why I'm here. And since I was told, you know, 3 years ago, 3 people in my family have now, 2 have been diagnosed, and then 1 is, I mean, 100% without a doubt, what my nephew Miles is having is myoclonic jerks. You know, additionally, there are other things that members of my family have that are not epilepsy. My brother has, Miles and Wyatt's dad gets severe migraines. And then our dad also, in addition to epilepsy, has neuropathy. All of these are neurological. And again, it's not on my mom's side of the family at all. It's only on my dad's side of the family. And when I asked my dear, I won't say sweet, my dear 94-year-old grandma, who I love to pieces, is there anybody in your family that you know of at all? And, you know, no, she doesn't know. But I don't know that she would tell me. I honestly don't know. I think it's a burden. It's a burden for my dad to know this. And it's taken a long time for him to be able to talk about it. And, you know, he's still will say, oh, I can control the jerks. And we know that that's not true. So anyway, my time is about up, and I just really want to, I hope you learned a little bit about JME. And like I said, JME is one of the more common of the genetic epilepsies, and one of the more controlled. And so it's not talked about as often, but it is important. And it's important to understand the signs, just like with any epilepsy syndrome, to understand the signs and what's going on. You know, I mean, if my nephew Miles gets in the car and has a seizure because nobody believed them, I mean, that could be tragic. And I think we all understand that. And when we say it, oh, JME, myoclonic jerk, there's much more to it. And it's important to understand that. It's a common epilepsy, but it's also idiopathic and it's genetic. And if you think that if you have JME or your child has JME, it would be, really important. I would suggest to talk to your physician or your neurologist or your epileptologist about having some genetics testing, and really kind of look into your family history to see what's there, and really try to delve deep, and even just the jerks. And for some people, the jerks are much more subtle than the others. But to try to find them and look for them, and to understand the health, because we all know it's important to understand our health history, and it will be important for us and our children and our future children and grandchildren and families. So that is all that I have. And, I know we're going to move on and get into some real, some further, genetics that are much more complicated than JME. And it's definitely have a treat in store.
Thanks, Shannon, and thank you for sharing your journey with us and for all you do in the epilepsy community. Remember, if you have questions for Shannon, make sure to add them to the chat box. Now, I would like to welcome Dr. Wirrell, who is the Director of Pediatric Epilepsy at Mayo Clinic and co-editor-in-chief of Epilepsy.com. Her main interests are in early onset epilepsies and in comorbidities seen in children with epilepsy. Welcome, Dr. Wirrell, and thanks for joining us today.
Thank you very much. It's a pleasure to be here, and thank you very much, Shannon, for sharing your story. I was wondering if we could go to the slides, please. I could get the next slide. Perfect. And maybe, so I'm going to be talking on epilepsy and genetics, and we'll go to the next slide. Could I get the next slide, please? Perfect. So we will first of all review a little bit about genes and DNA, just a bit of a primer. We'll talk about what types of epilepsy might be genetic. Then we'll address, who should actually be tested and how is the testing done. And I think importantly, how might knowing a genetic cause actually help? So next slide, please. So when we look at genes and DNA, we know that our bodies are made up of billions of cells, and each cell actually contains a nucleus. And in that nucleus's core, the nucleus is the core, and that actually contains the DNA. And what the DNA is really a blueprint of that controls how the body develops. And the DNA is packaged into chromosomes, and each of us has 23 pairs of chromosomes, including the X chromosome. So girls have 2 X's and boys have an X and a Y. Next slide, please. And if we look at this slide, this kind of tells us in a simplistic way how we think about genes and chromosomes and genomes. So if we think about this as a book, each sentence in the book, that would be each gene. And then if we look at genes, they're packaged into chromosomes, just like sentences are packaged into chapters. And then the entire genome is actually the book. So we'll go to the next slide. So can epilepsy be genetic? And we know that there are many genes that actually contribute to or can actually in themselves cause epilepsy. And we say that epilepsy is genetic if there is a known or a presumed genetic cause that's associated with epilepsy. What's important to recognize, however, is that genetic does not necessarily equate to inherited. So some of the changes that we see in children can occur what we call de novo. So that's a new change in the child's genome, and the parent does not have that change. And so in that situation, it's a genetic cause, but it's not inherited because the parents don't have it. And so the likelihood that they will pass it on to their other children is pretty low. Furthermore, having a genetic cause also does not exclude that there also may be an environmental contribution to the epilepsy as well. Next slide, please. So when we think about genetics and epilepsy, there's really 2 main big groups that we think about. So one is something called polygenic inheritance, and polygenic just means many genes. And this is a situation where we all know that we inherit many genes, and there are lots of genes that have a little bit of a contribution to developing epilepsy. And if you inherit enough of these genes that have a little bit of a contribution, then you can actually develop epilepsy. Furthermore, in those situations, oftentimes there's environmental factors as well. And so if there's a polygenic inheritance or many gene inheritance, if you have other family members, there's a slightly higher chance that they're going to develop epilepsy, but they're certainly not guaranteed to develop epilepsy. Next slide. So this has been looked at in large family groups. And so the question often comes up, what is the risk of, my relatives having epilepsy? And first-degree relatives of a person with epilepsy have about a 4.7% chance of developing epilepsy before 40 years of age. And that number is a little bit more than threefold higher than the general population. So they're a little bit more likely, but they're not, highly likely. It really depends, however, on the type of epilepsy that is in the family. So if epilepsy is focal, meaning it starts in one spot in the brain, first-degree relatives have no higher rate of developing generalized epilepsy, but about a 2.6-fold higher rate of developing focal epilepsy. If epilepsy is generalized, however, as is the case in Shannon's family, first-degree relatives have an 8.3-fold higher rate of developing generalized epilepsy than the general population, and still a 2.5-fold higher rate of developing focal epilepsy. Next slide. So the other type of big group of genetic conditions we think about are single gene disorders. And here is when there is a gene and the gene, and just one gene, is responsible for the epilepsy. So if you get that gene, you will develop epilepsy. If you don't, you will not. Now, sometimes these genes can be inherited from parents, but more commonly they occur as a new change in the child, so what we call a de novo change. What's important, however, is there is a condition that's called mosaicism, and what mosaicism means is that a person can have sort of two copies of, or two different types of cells. One type of cell can actually have this genetic change and one cannot. And particularly when a child is being conceived, the sperm or the egg can actually develop from that copy that has the abnormal gene. So it's important, even if it's not in the family, that this condition called mosaicism be excluded, and that would mean talking to a genetic counselor and seeing a geneticist. Next slide, please. So what types of epilepsy can be genetic? Well, probably the biggest group that we see are what we call the idiopathic generalized epilepsies. And I think Shannon has given us a very nice overview of the situation in her family. So childhood absence epilepsy, juvenile absence epilepsy, juvenile myoclonic epilepsy. We know that those are more commonly seen in first-degree relatives. And while they are considered genetic, it typically is multiple genes that are leading to this genetic predisposition. So it's what we call polygenic, and oftentimes we don't find a clear causal gene. Another type of epilepsy that is often genetic are the severe epilepsies that start in early life, particularly if the MRI scans are normal. And about half of these children will be found to have a genetic cause. And the earlier the onset of these epilepsies, the higher the likelihood of finding a genetic cause. And then there also are groups of families who have focal epilepsies, and we now recognize that some of those families also carry genes that give rise to a higher rate or higher risk of epilepsy. Sometimes those genes can actually cause structural changes in the brain, like tuberous sclerosis complex. Next slide. So who to see? The first person that most people see when they have a seizure disorder would be a neurologist. And neurologists typically see persons with first-time seizures or persons who have drug-responsive epilepsy. If the epilepsy, however, is not responding well to medication, so your seizures are persisting, then typically you move on to an epileptologist. And both neurologists and epileptologists have some knowledge of genetics. However, if there's a question of a genetic change, typically you would see a geneticist as well as a genetic counselor. So the geneticist would order and interpret the genetic tests, and the genetic counselor actually looks at the history, counsels on what is appropriate testing, and once they identify a specific gene, they can also help with identifying which family advocacy groups you can become in contact with, and also provide resources to you for that. Next slide. So why is genetic testing for epilepsy important? Well, one is that it really helps identify what is the cause of the epilepsy. we talk about the diagnostic odyssey, and these are people that go through multiple different tests, several MRI scans, surgical workups, lots and lots of blood tests, sometimes spinal fluid tests, and it's a lot of involved testing. And it's really important, I think, to kind of give an answer and find out what that answer is. Genetic testing sometimes can identify a gene that will help select the best treatment, and it can also give us information on how that epilepsy is likely to behave, if the seizures are going to control or be controlled with medication or not, and then also the risk of other comorbidities, learning problems, or other behavior or other issues. Next slide. Genetic testing also informs family members of their own risk for epilepsy and their chances of having a child with epilepsy. It can provide an opportunity to participate in certain research studies, and it can also allow you to contact other people who have the same type of epilepsy that you or your loved one has. So advocacy and peer support, and that is really important. Next slide. So the question is, should everyone with epilepsy have genetic testing? And that's probably not needed. It can certainly be considered for anyone with epilepsy if there's not a known cause, but you are more likely to identify a genetic diagnosis if the epilepsy is difficult to treat and you don't have another answer. If the person has other neurodevelopmental or other neurological symptoms, or if there is a strong family history of epilepsy. So particularly in that situation, it's important to talk to your neurologist or your epileptologist. Next slide. It is also important to understand the implications of genetic testing before that is done. And so this is really where genetic counselors come in to really educate you before you go through that testing. So there are medical implications. Some of the genes that are tested for may have implications to symptoms other than seizures, and those implications can extend to relatives. There is reproductive implications, so the risk of passing on an abnormal variant associated with disease to your future children. There's psychological implications if you find out that there is a gene that's causative, and particularly if you have children and you're concerned about that. And then insurance and financial implications as well. So all of those are important to discuss with a genetic counselor before the testing is done. Next slide. So how is genetic testing done? Most of the genetic tests are actually performed on DNA, and that's really easily obtained from a blood sample. Sometimes you can get it from a saliva or a cheek swab sample. Next slide. And there are different genetic tests that can be done. There is no single test that can diagnose all genetic epilepsies, and even after you've been through testing, none of those tests can definitively exclude a genetic cause. The most common tests that we do would be tests that actually look at a group of genes that are associated with epilepsy. They're called epilepsy gene panels. We also look for specific changes in the genes, something called a microarray or chromosomes. And then a more extensive testing is whole exome sequencing. And it's important that you get that genetic counseling so that you actually understand what is being done, what is being tested for. Next slide. So the epilepsy gene panel is the most common one that we do, and it analyzes the most common genes associated with epilepsies. Most of the panels now are testing several hundred genes, and there's a number of different companies that do that. There's what's called targeted testing, and that is if you really are looking for a single gene. And so it's used if you really suspect very highly that this epilepsy is due to this gene, or if there's a known family history of that gene change, and you're really looking to see if that gene is present. Otherwise, we don't really use targeted testing so much. Next. A chromosomal microarray, that actually involves analysis of a person's chromosomes, which are the structures that contain the DNA. And what it does is it looks for any missing bits or any extra pieces that cause imbalance that could lead to epilepsy. And then the other type of test that is, I think, increasingly being done is something called whole exome sequencing. And this actually looks at the entire DNA code, so the entire book of all of those all of that genetic information for changes associated with epilepsy. It is actually similar to the epilepsy gene panel, but it looks at a much larger number of genes, including rare and newly discovered genes, and also looks for genes that are not necessarily associated with epilepsy, so other potential disease-causing genes. Next slide. So once you get the genetic testing, there's really three possible outcomes of that. One is you have a positive test result, and that's where we can say, yes, we've identified a genetic change, and we know that this genetic change is associated with your epilepsy. And so that's very helpful because you can get very specific information on what is the risks of this being seen in other family members, what is the best treatment, things like that. Or you could have a negative test result, which means no genetic cause of epilepsy was identified. But as I've said, that doesn't completely rule out the possibility of a genetic diagnosis because we don't have the perfect test yet. Sometimes you may want to consider further testing. And then next slide. And then the third possibility, and this is probably the most problematic for people, is it comes back uncertain. And we often use the term a variant of uncertain significance. And what that means is that a genetic finding was detected, but we don't know the impact of that finding. We don't know if that finding is related to disease, or if that finding is just a benign change that is not going to be associated with disease. What's important if you have a variant of uncertain significance is to talk to your physician, to the geneticist, to really sort of look at correlating the clinical picture to this particular change. And sometimes we know that certain genes can be associated with specific seizure types that come on at certain ages. What's also really important is staying in contact with your genetic team, because oftentimes every couple of years they will relook at those variants of uncertain significance. And as we know more about epilepsy and genes, sometimes we can actually reinterpret that, and we can say, that change that we found is definitely associated with epilepsy or definitely not. Next slide. The next question is, will insurance cover the cost of testing? And that really depends on the insurance coverage that you have. Most of the plans require pre-approval or prior authorization before testing. And again, here is where genetic counselors can be very helpful. Next slide. So the importance of really knowing the cause allows families to connect with others. And the Rare Epilepsy Network, I think, has done a really great job of that. And you'll hear from Kim about her experience with that. Next slide. So genetic testing in epilepsy, just to summarize, you want to talk to your healthcare provider to see if this is the right option for you or your loved one. You need to understand the potential implications of testing before that test is done. You want to work with a knowledgeable clinician, and you want to use a reputable lab, and recognize that the results can inform treatment. They can inform what the outcome is likely to be, as well as give you information on risk to other family members, and opens the options of other clinical trials as well. And I think that is my last slide. Thank you very much.
Thanks so much, Dr. Wirrell. Our last presenter for this session is Kim Nye, the president and co-founder of the TESS Research Foundation, whose aim is to find better treatment options and ultimately a cure for SLC13A5 deficiency. Kim lives in California with her husband, Zach, and their 4 kids. 2 of their children have SLC13A5 deficiency. As a mother of 2 children with epilepsy, Kim has witnessed hundreds of thousands of seizures, a claim she hopes fewer moms will be able to make 5 years from now. Now, don't forget to add your questions to the chat box for a short live Q&A after Kim speaks. Welcome, Kim, and thank you for joining us today.
Thank you so much. Hi, I'm Kim. I'm here today to share my family's journey, the mission of TESS Research Foundation, and insights on the progress being made in the field of genetic epilepsies. That's a lot to tackle in 10 minutes, so I'm going to dive right in, and I'm going to start with a story about why genes matter and why a genetic diagnosis may matter to you, not to doctors or researchers, but to you and your child. And I'm going to use my family's experience as an example, but I hope our journey will help you on your journey. So this is my daughter, Tessa. She was born in England, where my husband and I were graduate students in 2003. We had serious conversations before her birth about whether I should fly back to America to deliver our daughter so that she would be born in the United States and therefore be able to be a presidential candidate someday. To say that our expectations for her future were high is an understatement. Needless to say, I thought that I was having a healthy baby. Our doctors told us we were having a healthy baby, and I delivered what seemed to be a healthy baby. But when Tessa was 12 hours old, she turned blue during her first bath. She also started having trouble feeding, and everyone kept saying that Tessa had physical strength abnormal for a newborn. It turned out that Tessa was having seizures. That supposed strength was her muscles contracting involuntarily, and the trouble feeding was because her seizures were so frequent that she couldn't finish a feeding without having seizures overtake her body. Something was very wrong, but that something would elude us for a decade. Tessa went on to have hundreds of thousands of seizures. Most of them were short, like the seizure in this video. Play the first video. You okay? Yeah. She's right back to normal. But some of them were very, very long, like in this second video.
We love you, Tessa. She's still breathing, so.
She is still breathing.
She's okay, girls.
It's a much more serious type of seizure. Tessa had dozens of long hospital stays under her belt by the time she entered preschool. We knew our ambulance crews by name. Tessa tried dozens of medications in different combinations to little effect. We traveled across the country to see the best neurologists. Tessa's diagnosis shifted from benign idiopathic epilepsy, meaning doctors thought she would be just fine, to catastrophic epilepsy, meaning doctors were not sure that she would survive. You can see in the highlighted section of this slide that Tessa was having up to 53 seizures per hour. We had every genetic test available at the time, but honestly, genetic testing could not answer many questions for families in 2003. In 2007, I gave birth to a healthy baby girl, and in 2009, our family was again blessed with a healthy baby girl. In 2012, we received news from a research lab that Tessa had what was called an ATP1A3 mutation, and that's a genetic marker for a disorder called alternating hemiplegia of childhood, or AHC. My husband and I were tested. We were both negative. AHC is almost always a de novo mutation, which means it is not inherited. We celebrated, and a year later, we decided to have another baby. When I was 7 months pregnant, we found out that an error had been made in that research lab. Tessa's sample had been switched with another child's. Tessa did not have AHC as the cause of her epilepsy. We were back at square one, but we were still hopeful that our fourth child would be healthy. On August 26, 2013, I gave birth to a seemingly healthy baby boy named Colton. My husband and I knew our family was complete, and we were confident that we were the luckiest people on the planet. Around 2 in the morning, Colton started having trouble feeding. He started looking blue. I remember calling the nurse and telling her I suspected Colton was having seizures. Our neurologist, Dr. Porter, transferred him to the NICU for observation. Colton was indeed having seizures, lots of them. I went from dreaming of his future college graduation and my future grandchildren to knowing that my son would likely never talk or live independently, just like his big sister. Dr. Porter put Colton on the medications that had been the most successful for my daughter. It took us 4 years to find out that a medication called Diamox helped Tessa. Dr. Porter started Colton on Diamox when he was 3 days old. And whereas Tessa was in and out of the hospital for years, Colton came home from the hospital at 2 weeks old, and he has remained amazingly stable. We immediately reached out to every researcher and geneticist that Tessa had seen. We sent samples of Colton's blood to the NIH Undiagnosed Disease Program, to Baylor, even to the doctor who had misdiagnosed Tessa with AHC. None of them could find a genetic marker. When Colton was 3 months old, a friend introduced me to Dr. Matthew Bainbridge, who was a genetics researcher at Baylor at the time. We talked for quite a while about the kids and our family history. And then a few months later, I got another call from Matthew. And he said, "I think I found the gene, and I think there's something to do about it." Matthew had found compound heterozygous SLC13A5 mutations in Tessa and Colton. This genetic marker suggested that Tessa and Colton had a citrate transporter disorder. We started hearing about more and more children diagnosed with SLC13A5 mutations. They all had the same symptoms, difficult to control epilepsy beginning shortly after birth for no apparent reason. So how is Colton doing? Did he benefit from diagnosis? I wish I could say that Colton is perfectly fine. He is not. Although we have controlled his seizures, he is now 7 years old with minimal language, and he just started walking. But I do feel confident that he benefited from having a big sister who had spent a decade trying different treatment options. Having an early and accurate genetic diagnosis is like giving every child a big sister. It helps parents with family planning, it lets doctors know that they are dealing with a serious epilepsy, and so much more. And how is Tessa doing? Tessa is now 16, and she has been seizure-free for well over a year. I know that is not a super long time, and it may not last, but we didn't even think seizure freedom was a possibility for her at this point. How did we stumble across a treatment that made her seizure-free? The answer is genetics, data, and our amazing doctor, Dr. Porter. Because I am better at doing something than doing nothing, we formed a nonprofit organization called TESS Research Foundation. I'm not going to go into too much detail about our organization, but I invite all of you to email me if you want to learn about how to start a nonprofit organization or some of these smaller nonprofits that are geared at genetic epilepsies. Our mission at TESS Research Foundation is to improve the lives of families affected by citrate transporter disorders by funding cutting-edge research. This cutting-edge research includes simply listening to parents whose children have received the same genetic diagnosis. We listened to parents about what seizure medications their children were taking, what seizure medications seemed to help, what seizure medications seemed to make things worse. At first, the data was really messy, but over time, we saw that there were a handful of medications that children who were seizure-free remained on. My daughter had tried all those medications in the past, but we retried them in combination and her seizures stopped. Tessa is not a typical child, but her life is better. Sorry, Herman. Our whole family's life is better thanks to her seizure control. I'm no longer leaving a cart full of groceries at the store in order to rush to her school to meet an ambulance. I no longer keep my rearview mirror focused on Tessa when I drive. We all sleep better at night. When we started TESS Research Foundation, almost nothing was known about citrate transporter disorders. There were less than 10 kids diagnosed. There was no research funding, no patient registry, no advocacy organization, no research conferences focused on this gene, no free or accessible genetic testing, no predictive biomarkers. There was a mouse model and a fly model of the disorder, but there were no treatment guidelines. There was no understanding as to why a lack of citrate transport caused epilepsy, and there were certainly no disease-modifying treatments or drugs in development. Fast forward to today, and we know a lot more. We now have more than 100 kids diagnosed. We have over $3 million in funding going to SLC13A5 epilepsy research. We do have a patient registry. We are the only organization in the world dedicated to this disease. We've held 4 research conferences, and we have free and accessible genetic testing for families. We may have some predictive biomarkers. We've developed more than a dozen cell models and biobanks. We do have some treatment guidelines. We still do not understand why a lack of citrate transport causes epilepsy. And although there are no disease-modifying treatments at this time, we do have a gene therapy treatment in development. My family has experienced the evolution of genetic testing and precision medicine in epilepsy firsthand. Genetic testing has come a long way, and I am confident that genetic epilepsies will have true cures in the near future. These cures will be possible because of organizations like the Epilepsy Foundation and TESS Research and all the patient advocacy groups that make up the Rare Epilepsy Network. These cures will be possible because of families like yours who push for genetic testing for their child. Thank you so much for letting me share my story today. I look forward to hearing yours.
Thank you, Kim, for sharing your family's journey with us and for doing what you can to help other families. And now, as you see, we have all of our speakers on stage. We're going to do a quick Q&A. We have a few minutes here. And so if you have questions, please put them in the chat box. and we'll pull them out and ask our participants here. Okay, so the first question I'm going to ask is of Shannon. And so Shannon, after genetic testing was done, did your doctor change your what he wanted you to do, new medications, or what did he do or she do?
No, in fact, I was actually in a really good place where I was, and I was on the right medication for the kinds of seizures that I was having. We just didn't know that it was genetic, I guess, or I had never been told to that point that it was genetic. But I take Depakote. Everybody in my family takes Depakote. For us, that seems to be, if you're, a Sparling and you have epilepsy, you take Depakote. It's what works. I take a lot of it right now. I take about 3,500 milligrams a day. So if I have more seizures, that I'm kind of at the max level right now. But things haven't changed. I just continue to go up. And I think Depakote is across the board the medication to take for JME. Dr. Wirrell, you can tell me if I'm, but I think, for most people with JME, that seems to be something that works.
Okay.
Yes, I would agree. It's one that I think it's probably the most effective one for JME. There is a potential concern in women of childbearing age with
Right.
Depakote and the risk of higher complications in the pregnancy and problems with the babies. But I think otherwise it's a very effective medication.
Yes, and I will just say I actually went off for my 2 pregnancies, and my seizures were out of control during my pregnancies. But I was off of Depakote during both of those pregnancies.
Okay. And Dr. Wirrell, question for you: if a neurologist or a doctor doesn't ask you to do genetic testing, is it okay to ask them? Should families and parents and individuals be proactive?
Absolutely. So I think that, genetic testing is not going to be for everyone. And I think if there's a good reason why genetic testing shouldn't be done, that's a conversation you and your doctor will have. But I think if there's a question in your mind, would it be helpful to get genetic testing? I would definitely recommend that you have that discussion with your doctor.
Okay, perfect. And we have just time for one last question. So Kim, this one is for you. How can somebody go about getting involved with the TESS Research Foundation?
Yeah, I would encourage you to go to our website, tessresearch.org, or to send me an email. I'm kim@tessfoundation.org. So I'm happy to share more. And that slide of the Rare Epilepsy Network, there are so many great groups that are really collaborating well to try to help families and to help find treatments and cures, particularly for these genetic epilepsies.
Okay, perfect. Well, I'm going to have to close our Q&A session there. Thank you very much to the 3 of you for speaking today and for really trying to help our epilepsy community. It's obviously greatly appreciated. And for everyone else, don't forget you can connect with others in the community by clicking on the attendee tab. And now we're going to take a quick 5-minute break before our next session on telemedicine.
We are SK Life Science. We explore the complex mysteries of the brain to find answers for patients, caregivers, and healthcare professionals around the world. The SK Life Science family is passionate about improving the lives of people with epilepsy. Together, we work toward this goal every day.
We are here to help the epilepsy community and support the efforts of the Epilepsy Foundation.
For more than 50 years, the Epilepsy Foundation has been fighting for the 3.4 million people living with epilepsy in the U.S.
At SK Life Science, we share in the Foundation's sense of urgency.
We're working to help increase awareness, innovation, and opportunities for community connection.
We know we are stronger together, and we're dedicated in the fight to end epilepsy.
Well, welcome back, everyone. Before we move on, I would like to thank our Explorer sponsors, SK Life Science and UCB. Thank you very much for your amazing supports. Our next session is Telemedicine, How We Got Here and What's Next. During this session, we'll learn about telemedicine from two epileptologists. Dr. Herman will talk about how we got here, where we are now with telemedicine, and what's next with it. Dr. Joshi will talk about how to make the best use of a telemed appointment, since it's all still new for a lot of people. As with the other sessions, it will be followed with live Q&A, so submit your questions using the chat as we go. Now I'm excited to welcome our first speaker, Dr. Susan Herman, who is the director of the Epilepsy Program and a professor in the Department of Neurology at Barrow Neurological Institute. Her expertise includes the treatment of drug-resistant epilepsy. Dr. Herman is currently a co-principal investigator of the Epilepsy Learning Healthcare System, a network where families, community members, clinicians, researchers, and healthcare leaders can collaborate to improve care and outcomes for people with epilepsy. Welcome, Dr. Herman, and thanks for joining us today.
Great, thank you very much. I'll just wait for my slides to come up. Great. So I'm going to give a story of what happened with telemedicine in epilepsy, and particularly focus on the rapid change that happened around the time of COVID, and explain a little bit about why telemedicine was not used frequently before COVID, and how we can potentially maintain the gains in telemedicine in the future. Next slide. These are my disclosures. I just want to point out that I do receive grant support from the Anderson Center for the Epilepsy Learning Healthcare System, and then I'm president of the National Association of Epilepsy Centers, and I'll present some data from that during this session. So I'll first start by talking about the different types of telemedicine. So the first, and the one that many of you may have already experienced, are video and audio visits. So either phone visits or visits over Zoom like we're doing right now for outpatient visits, or sometimes even inpatient and emergency room visits. During COVID, we've also been doing a lot of phone-only visits. But there are a couple of other types of telemedicine that may be applicable for the future. One are online digital evaluation and management visits. And these are visits that are done over a patient portal or secure email, where you are sending information back and forth with your physician or other staff in your provider's office through an electronic portal. And then finally, there are interprofessional internet consultations, and these are doctor-to-doctor visits, usually over electronic format, to discuss management of a patient. So a primary care physician or a general neurologist could potentially speak to an epilepsy specialist or a genetic specialist in order to get more information about the management of a particular patient. And then finally, there's remote monitoring, which is devices that are used in the home and send information electronically back to your provider. Examples of this would be blood pressure monitoring or blood sugar monitoring. And here I'm going to talk mostly about video and audio visits, because I think those are the visits that have had the most change over the past few months. So there are many advantages to telemedicine, and hopefully some of you have experienced this already. So first, it really puts the focus on the patient. You have much more control over when the visit happens, where the visit happens, what your environment is like during the visit, which is very helpful. You have potential for instant access to information. So most of the systems require you to have access to a patient portal in order to set up a telemedicine visit. And then many of your medical records will be available to you immediately. I think the biggest advantages are in terms of convenience. So it takes less time to do a telemedicine visit. You don't have to drive to the physician's office, pack up all of your materials, your child's materials, and head off to the office visit. And in many cases, there are more flexible visit times, and off-hours visits are sometimes more feasible. You also don't have to deal with parking and the other inconveniences of going to the physician office. There may be lower costs for patients. At least during COVID, many of the copays for visits have been waived. Whether that is going to be maintained has not been entirely clear, but it's certainly not higher cost for patients than a traditional visit. So with all of these potential advantages, you might ask, why hasn't telemedicine already been a standard of care for patients? And that's because there's a lot of barriers. Prior to COVID, many insurance companies did not cover telemedicine or covered it at a much lower rate than a traditional office visit. And in addition, you could only talk to a patient through telemedicine if they were in a specific telemedicine approved site. So they needed to be in an office, not just in their home. And we were only allowed to see follow-up patients and not new patients. And so it was very difficult to provide a broad range of services. In addition, there were limitations on what type of platforms you could use to talk to patients, and the systems for telemedicine were quite expensive and difficult to set up. Finally, there were state-by-state licensure requirements, and so if you were in Arizona, as I am, and I wanted to see a patient in Nevada or Colorado, I actually had to have a license in those states as well. And that's a very expensive and time-consuming process. So the ability to see patients over long distances was limited. We also had concerns, and what happened during during COVID is that many of these barriers were broken down. So almost all insurance companies now cover telemedicine at the same rates as an in-office visit. The patients can be seen anywhere that they are, at their home, at their office, et cetera. And we can see both new and follow-up patients. The Centers for Medicaid and Medicare opened up all of the options for the platforms that we can use, so that we can use things like Zoom and FaceTime and other ways to communicate with patients that make it much easier. And the requirement to have state licensure has been waived during the COVID emergency. And it's going to be really important to maintain all of these increased access issues once we finish the COVID emergency in order to maintain telemedicine. The other group of barriers were related to interactions with the patient. How do you do a neurological examination over telemedicine? What are the abilities of patients to log on and use the technology required for telemedicine? We know that there are a large number of patients who either don't have the equipment necessary for telemedicine, or they're not technologically savvy and they have difficulty using the technology. We found that it's difficult to collect information from patients before the visit and provide information after the visit. All of the forms that you typically fill out before you see your doctor in the waiting room, and all of the materials that you get handed at the end of the visit, patient information, education, et cetera. And we don't have a great way to do that in the new telemedicine age. And then finally, some patients just say they're not interested in doing telemedicine. They don't think it's going to be a good experience, and they would prefer to not have follow-up than to do a telemedicine visit. So how prevalent was telemedicine before COVID? The National Association of Epilepsy Centers did a survey back in March that looked at how centers were doing telemedicine, and we found that more than 80% of centers had little or no telemedicine experience, that they were doing less than 10% of their visits by telemedicine. And that's a really sad statement, that we were really not using this potentially very patient-friendly technology. And for the centers that were using telemedicine, most of them had switched over to using general video conferencing, things like Zoom and FaceTime and other types of telemedicine that hadn't been available before COVID. And of the centers that were now doing telemedicine, most of them were doing live video. And for patients who didn't have the option to do video conferencing, we're doing telephone only visits. So then what did this look like in the onset of COVID? So this is from the Barrow Neurologic Institute, what we did with telemedicine. So we had 0 telemedicine before COVID started. One of our attendings had been working for about 2 years to work out the contracts and the requirements, pick a vendor to do telemedicine. And then on March 11th, because of the COVID emergency, we closed all of our clinics and we moved all of our visits to phone visits. The next Friday, we signed a contract with Zoom. And the Monday after that, we actually started doing Zoom visits for 2 of our specialty groups, epilepsy and movement disorders. We then created a system for training patients how to use the technology. And by the middle of April, more than 80% of our usual clinic visits were being done on Zoom. So 2 years to try to get it up and running before COVID, and then a little more than a month to completely switch over to telemedicine during COVID. So one of the things I think is very encouraging about this is, we actually can change how we do things. There's nothing like an emergency to force change and to let us look at new innovative ways of providing care to patients that may be useful in the future. This was a huge effort. We actually had most of our department involved in this. We had the information technology group that developed all of the Zoom interfaces, provided training, set up all of our equipment in the hospital to do Zoom visits. So you can imagine that we don't have video cameras and great audio in most of our clinic offices, so they were involved in doing that. The clinic staff actually trained all of the medical assistants and all of the other staff to talk to patients and to collect the information that we needed to collect over telemedicine before the physician sees the patient. And then we had a physician group that worked on, how to do a neurologic exam, how to take a neurologic history over telemedicine, and trained all of our residents and fellows to do that as well. And again, all of this happened over the course of about a week. We also quickly recognized that many patients and families were unfamiliar with telemedicine. And so we developed a training sheet, a checklist that patients and families could use to make sure that they were ready for their telemedicine visit. And this was done in conjunction with the Epilepsy Foundation and the Epilepsy Learning Healthcare System. They actually piloted this checklist with a group of patients and family members to make sure that everything that people needed to know was available to them before the visit. And this information is available on the Epilepsy Foundation webpage. So this is what happened in telemedicine at Barrow. I told you over that about month-long period. And you can see that our average number of visits per week was about 90 to 100 patients. When we first switched over to telemedicine, that dropped quite a bit. But then once we got our telemedicine up and running, we were actually able to see many more patients than we were seeing before telemedicine. And this is because it was easier for patients to make their appointments. There were very few no-shows, very few patients who couldn't keep their appointment. We also had less time in between patients, to clean the room and switch things over. So we were just more efficient and able to see many more patients. And I think this bodes well for access to care. There's often very long waiting lists for patients to get in to see an epilepsy specialist. And if we can increase the number of patients that we're seeing, this could actually be very useful for the future. And this is what happened from the patient side. So we first started out with our technologist IT group training patients over telemedicine. So they would actually log on with the patients, make sure that they knew how to do a Zoom meeting, make sure that they had all of their technology in place. And over the course of this month, we found that fewer and fewer patients needed that training because people were using Zoom for pretty much everything in their life and had already had experience with it. And on the other hand, we actually saw that the length of our visits for the neurologist was going up, and that's because we started seeing new patients in addition to follow-up patients over telemedicine. So we were able to actually worked through our wait list, which was about 4 months at the beginning of COVID. And now if you called my center and said you wanted an appointment, I could see you on Monday. We have no wait list whatsoever because of our increased volume and our ability to see many more patients. Most of our patients were using either a desktop PC or a mobile phone in order to do their telemedicine visit. So this was very useful as we developed our patient materials to know how they were connecting to the visits. We did see some potential problems, however. So first, in terms of demographics, we showed that patients who were non-English speaking, patients who were Latino had a much lower rate of telemedicine than our other patients. So this is during COVID, we actually saw a significant decrease in the proportion of patients who were Hispanic or Latino who were doing telemedicine. And we think that's because they may not have been able to get the information in Spanish about the fact that we were doing telemedicine. These patients may also be limited in terms of having the technology needed to do telemedicine visits, or may be less willing to do a telemedicine visit. And the other group of concern is that older patients, those over age 65, there was also a significant limitation in terms of their ability to do a telemedicine visit. We did another survey through the National Association of Epilepsy Centers in August, and we can see that unfortunately the pendulum has swung back in the other way. So now 50% of centers are doing less than 50% of their visits by telemedicine. There's really been a push from hospitals and clinics to go back to in-person visits rather than telemedicine visits. And we can talk a little bit in the Q&A about why that might be and whether that's a positive change. So in summary, telemedicine visits are feasible for providers and satisfactory for patients. We still have some concerns about equity. There may be limitations to devices or limitations to technology. There may be patients who are unfamiliar with this or just not willing to use telemedicine. And unfortunately, one of the major drivers of telemedicine is whether these visits will be reimbursed and hospitals concern about adequate reimbursement. So looking forward to the future, we really need the voice of the patient to drive future telemedicine regulations. It's incredibly important that we have the voice of all of you to insist that telemedicine is an important part of epilepsy care, that these visits should be able to continue to be done at home, that physicians should have broader ability to do telemedicine over state lines, and that there be adequate reimbursement for the visits that's equivalent to the reimbursement that would happen if the patient was seen in the office. I think that this is going to really continue to be an important part of access to specialty care, particularly for patients who are far from an epilepsy center and really do need additional expertise. Telemedicine is a great way to do that. Co-management may be possible where you have a local physician who is communicating remotely to a physician in another area. And then finally, a huge increase in the ability for patients to communicate with their physicians electronically through patient portals and these digital visits. And I just want to thank everyone who participated in this, including NAAC, the Epilepsy Learning Healthcare System, and my entire team at Barrow. Thank you very much.
Thank you very much, Dr. Herman. And if you have questions for Dr. Herman, please enter them into the chat box so we can discuss them during the live Q&A. Now, our next speaker is Dr. Charuta Joshi. She's a clinical professor at Children's Hospital Colorado, Anschutz Medical Campus, and directs the Pediatric Epilepsy Fellowship Program there. She is also the director of Neurology Outreach Services, and she's currently doing clinical research in epileptic encephalopathies and the ketogenic diet. Welcome, Dr. Joshi. Thanks for being here.
Thank you very much for that introduction. As I wait to get the slides uploaded, I thank Dr. Herman for bringing a very important point across that I think we really need champions for telemedicine to make sure that this continues even post-COVID. So the title of my talk is Telemedicine 101, and this is geared more towards you, towards the patients and their caregivers, in terms of how you could help us, the physicians, make this visit very successful. Can I have the next slide, please? So I think the biggest disclosure for me is that I am biased towards the fact that telemedicine is non-inferior to an in-person visit, at least as far as my specialty for epilepsy is concerned. I have personally done telemedicine since 2001, and I feel extremely comfortable in my ability to extract whatever I need out of that visit to make it comparable to an in-person visit. At Children's Colorado, we've done telemedicine since 2011, and obviously those numbers have gone up significantly since COVID-19, as has happened in other centers. Now remember that as physicians, we give advice to our patients when outside physicians call us, even on the phone without ever seeing the patient. And if physicians feel comfortable giving advice about starting meds for patients that they have never seen before, this is certainly a step upward, because now we are able to see patients virtually live as you see me today when we do telemedicine. Now we all agree, both the patients and physicians, that there are certainly limitations to exam, but let's think a little bit here. Different scenarios, whether it is epilepsy or headache or movement disorder or learning disorder or developmental delay or even neuromuscular disorders, where I do not think that there should be any barrier for a patient to come up and utilize telemedicine. Now, there are certain types of symptoms, for example, back pain, that is very difficult to examine just via telemedicine at times, or when a patient is refusing to walk. However, you could still get some benefit from telemedicine when you move forward. Now, it is also important to note that just by doing telemedicine, you are not actually excluding. It doesn't mean that you cannot go in person to see the physician at a later time. And we do expect that once we see a patient, even if it's a new patient that we are seeing through telemedicine, if needed, the patient can be brought back in person for a visit in 3 to 6 months. From a regulatory standpoint, if you look at the ATA guidelines, it was never made a rule that new patients cannot be seen through telemedicine. As long as you are licensed in the state where you are seeing the patient, you can see the patient via telemedicine. It was our own barrier. It was our hospital's rule that we would not see new patients through telemedicine, but COVID changed all of that. Can I have the next slide, please? So what is my charge? So I think one of the things that I'm asked to do is to describe how things have changed at my clinic since the COVID-19 outbreak. And then how can parents of children or caregivers of patients with epilepsy coordinate care through telemedicine or telehealth during the clinic, and what does it look like? Or when is it appropriate to bring the patient to the clinic, and what precautions should be taken during this time? Next slide, please. So how have things changed at the clinic? So although clinics have reopened since May 11, majority of us, because we are socially distanced, cannot use clinic rooms just the same way as we did before. And so most of us are still using home-based telemedicine since March 11th, 2020. What is the meaning of home-based telemedicine? Home-based telemedicine is actually even a further narrow definition of social distancing, where patients are not going to an outreach clinic that has telemedicine facilities, but the patient is staying in their own homes, and the physician may be in their home office or in their office if it's not a cubicle where social distancing is not possible. Now, as I said before, we were already using clinic-based telemedicine and some home-based telemedicine prior to COVID-19. And at this point in time, now that everybody's using home-based telemedicine, we don't even have to worry about insurance pre-approval at this time. Note that for older patients, there used to be some barriers for telemedicine in the past, but those barriers have been removed, as Dr. Herman said, regarding copays. And patients have always loved it. In 2012, I had published my experience at the Child Neurology Society, and 90% of the patients loved it. As Dr. Herman pointed out, there are some patients for personal preferences that would like to come to the clinic, but the majority do love it. And at the height of our telemedicine home-based visits, we were doing 90 to 100 telemedicine visits per day, not per week, per day in April. Can I please have the next slide? So from an MD standpoint, if I need to see a patient from Wyoming, I need to have license in Wyoming if this is a non-COVID time. Or if I'm seeing a patient in Montana, I need to have a license in Montana. During COVID, for the patients that had already been seen from Wyoming, we were allowed to see follow-up patients if they were out of state. And remember that CMS changes laws very rapidly, and all of us need to be aware of them. In addition, DEA had also changed laws about prescribing controlled substances, things that people didn't think about very easily in the past. All rescue medications are controlled substances. So can I give controlled substances to a patient that I've never seen in the past? According to the past DEA laws, I couldn't. During COVID, now I can. So since I'm seeing new patients where I might prescribe rescue medications, that doesn't seem to be a deterrent from my standpoint, and shouldn't be a deterrent from the patient standpoint either. Next slide, please. So now we come to the crux. So how can parents of children or caregivers coordinate care through telemedicine? So parents or legal guardians can call the same scheduling number that they always have. They do need to sign a consent for telemedicine at my center ahead of that visit. And generally speaking, they shouldn't be worried about copay or non-covered services. We do have at all centers, as Dr. Herman pointed out, we do have medical assistants or registered nurses or IT folks to do what we call a tech check and walk you through what is required for that telemedicine visit. In a sense, what does that mean? What I have told my patients is that if you have a device that can stream Netflix, then that is the speed of internet services that you require for your telemedicine visit, and your telemedicine visit should go smoothly. Now, if you are using Wi-Fi from your home, then you may not incur charges. However, remember that if you are on your cellular device, then you could have cellular charges if your program doesn't cover the amount of time that is required for that video chat. Next slide, please. So the tools that I had put into place for Children's Colorado was that we knew that we were using various platforms. These are all HIPAA compliant platforms. At my center, we use something called video that is actually embedded in the patient's chart. But as Dr. Herman said, people have used Zoom, people have used Skype, Apple FaceTime, or Google Hangout. In the past, these were not recommended because they were not HIPAA compliant and they were not secure. Remember, as I said before, if you can stream Netflix, you'd be good. One important thing to note for patients is please download that platform ahead of time. I've had people where they're saying, well, I'm online at the other end, and they're still trying to download the platform to their iPhone or to the device, and that takes up a lot of time. This will not be free, as I mentioned before, if you're using cellular. And then you should also know the numbers to the IT department ahead of time to help you. One common thing that happens to my patients that use iPhone is that they've joined the meeting. I'm joining the meeting, and maybe an interpreter is going to join the meeting too. And if there are multiple folks, my patients suddenly lose audio. And what I tell them is just hang up. I'll stay online, and then they join that meeting room again, and then audio pops up. So sometimes you have to know a little bit of technology of how to get along, but I am very not tech savvy. And if I could figure it out, I think most anybody can figure it out. Next slide, please. Now, what does it look like? So remember that you are helping us to examine the patient. I cannot move the patient's arms or legs. So you help us do it. So suppose, just as you would have shown me in a clinic appointment, maybe you had a home video of the seizure or an abnormal movement, you can actually play it on your cell phone, and you could bring it very close to the camera, and then I'd be able to see the movements. And most times I am able to see the movements that you want to see, you want me to see. The other thing is that make sure that you are creative. Sometimes I have found that kids want to grab the camera, or even adults when they don't know, and if they see a mouse or if they see something on the keyboard, they want to play. So sometimes having somebody else to help with the patient while you are giving the history is important, and it's helpful to me. Sometimes what I do in my practice is I examine the patient, And if it's a toddler, I might say to the mother, you can put the toddler in the crib now so that the patient is safe and is not going off the staircase or something. And then I will talk to you to get the history so that I've gotten the exam out of the way first. I will use tricks like I play head and shoulders, knees and toes with the patient. And I know that if the patient can lift their hands up, they definitely have strength in their shoulders and upper arms. I'm also very keen on explaining to the family member what I'm trying to see, and sometimes they can help me. The other thing that I noticed the other day is mom had cell phone in her hand and she was talking like this and she was walking. So all that I could see, she was walking in the yard and all I could see was the treetops as I have shown here. And so try not to do that because this is an audio video visit. Try to keep the camera focused on either yourself if you're using a cell phone or on the child and follow them along. That helps us instead of making us dizzy. Next slide, and this might be my last slide, I think. Okay, when is it appropriate to bring a child to the clinic and what precautions should be taken? Remember that just because you had a telemedicine does not mean you cannot come to the hospital. So any medical emergency that is an emergency to you, for example, there is focal weakness, there is generalized weakness, there is abnormal level of awareness or consciousness, or if the patient goes into a long seizure, feel free to bring them to the hospital. However, before you do that, call the physician, go over rules about how many visitors may be allowed. And then also which hospital entrance you might need to use because multiple entrances have been closed off. And so it doesn't become, you're not wasting time just going around. Another example that I might want to give you is one of my patients had aspiration pneumonia the other day, and she was supposed to see me in person. And when I noticed her name in my schedule, I called her up and said, why don't we just convert this to telemedicine? The patient was tired. And the parent was really appreciative because I could see them in their home and they didn't have to come get screened and turned back because they had just been recently hospitalized. So think a little bit ahead. And I tell the physicians that telemedicine visits, if you are creative, can be very successful. Sometimes they need a little bit of prep time on my behalf as well as on your behalf to make it most successful. When you come to the hospital, make sure you have a mask on. And then the one last thing I would tell parents is please do not hoard medications. There was a time in March when there was a great fear that rescue medications would not be available anymore because people were just filling midazolam. So let's care and share during this time. Next slide, please. And that may be my last slide. Thank you very much.
Thank you, Dr. Joshi, for that wonderful and informative presentation. So now we have both of our presenters on stage, and we're going to move into our live Q&A session. Thank you to those of you who have added questions to the chat box. Please continue to do so. And if you haven't logged in to the chat box, it's right next to the live video to the right. You can put your name there or you can sign in anonymously. And please feel free to ask questions as we go along here. All right, so we do have a first question for Dr. Herman. This one is, has telemedicine opened up the opportunity for those in areas not in close proximity to level 3 and 4 centers, which could then accelerate treatment?
Yeah, so I think that that's one of the most important points. Right now, during the COVID emergency, the requirements for state licensing have been loosened. And so we are able now to see patients outside of our state and patients who are very far from our center. I'm in Arizona, and we have lots of patients who come from 2 or 3 or 4 hours away, and they love the ability now to do telemedicine. And so as we look forward to how these regulations will be placed in the future, I think it's going to be really important to think about how to maintain the ability to see patients over long distances, including out of state. It's a really important factor for access to care.
And I was just going to follow that. Yeah, I was just going to follow that question up about access to care, because there are many individuals and families who come from states where the waiting line can be days, if not weeks, to get an appointment. And so, do you see telemedicine in the future as really trying to alleviate some of that backlog?
still limitations on time, right? So, you have a certain number of hours in the day and a certain number of providers who can see patients. But what we found is that the time between visits has been very efficient, that we're working on ways to collect information from patients electronically before the visit that makes the visits a little bit easier. So we've certainly have been much more efficient. And even though we now have the ability to do some in-person visits, we've tried to maintain telemedicine as much as possible because we're just more efficient that way. And we're reserving the inpatient visits just for patients who really do need to be seen. We need to check something on their exam. They have a device that needs to be programmed, or there's some other reason that we need to physically see the patient.
Perfect. And I am going to add, as a parent with a child with epilepsy, I truly appreciate telemedicine visits, and does my wife. It has saved many, many hours of time either traveling to or waiting in the waiting room. And so it's been wonderful for our family, as I know it has been for many of the other families in the community who we speak to. And so this next, go ahead.
I was just going to say, it also gives us a better idea of what the family situation is, what the patient is experiencing at home. I certainly have seen a lot more artwork from patients, have had other family members able to participate in the visit. So sort of a richness of the experience that you would never get in the office environment.
That's a really good point. You can see a little bit more of what families are all about that way. Completely agree. Okay, this next question is for Dr. Joshi. A lot of attendees are asking in the chat about how they can raise their voices in favor of telemedicine. And I know that the advocacy team at the foundation is working on some of this, but what in your opinion can individuals and families do to make their voices heard?
Yes, I think it would be very important for families or for individuals to show that cross-state telemedicine visits are not in any way risky, because I think that could help licensure. That could also help with legislation with respect to why we are not allowed to see patients cross-state. And I think some of this would probably have to be done at the government level, locally as well as federally, to allow more of this. And so the more that people can say that there is no increased risk or there is non-inferiority, it would help that situation. And I can tell you that I analyzed 3,000 encounters for telemedicine over 6 weeks. And the number of patients that actually came back to the hospital or called within a month was only 50. So less than 4%. And so this is a small number. And most of them came back because there was a pre-planned EMU visit, or some of them came back for Botox, which you obviously cannot shoot through a telemedicine visit. But most of these were not emergencies in that sense.
Okay. Perfect. And can one or either of you describe a little bit about the license for telemed cross-state and how that process works and how that could be changed in the future potentially, and what would have to be done?
Well, I could take that first. So in terms of what is required, for example, when I applied for a license in Montana, it took a year to get that license. And on the other hand, because of COVID, I don't have a license in Wyoming, but for the patients that I have seen in Wyoming that have to travel a long distance, now that I could see them in follow-up, and that was allowed by CMS, they don't have to travel cross-state. I think it would have to be a body that writes to the legislation that makes these rules, to the licensing bodies, which are state dependent, unfortunately. So, for example, for Wyoming, for them to relax the rules of how a Coloradan can see patients, it has to be the Wyoming board. Now, possibly New Mexico board might say, well, I don't agree with that, and I won't cover malpractice, for example. That makes things very risky for us. So it has to be probably cross-state and also at a national level.
Right, and because we could potentially look at, maybe I'll just do a certain number of states around where I practice, but there are experts in epilepsy who have such specialization that they might want to see patients with a particular disease across the whole country, right? There's one or two providers who really have expertise in a rare epilepsy. So each state that the provider is licensed in, it can take 6 to 12 months to get the license done. It usually requires submitting paperwork to about your training and your previous experience. It's about a 2-day process to collect all the information necessary, with fees to have the information sent. And then it costs between $600 and $1,000 per state to actually get a license. So from a physician point of view, that really isn't feasible. But I think that there would need to be a push to create some sort of telemedicine specific licensing that had regulations that were the same across the entire country. There has been some effort along those lines. So there's a group of states that have agreed to sort of a common licensing, but it still requires the physician to get licensed in each individual state and pay the fees for each individual state, which is really not feasible.
Okay, so still some work to be done, but hopefully we're heading in the right direction. All right, and Dr. Herman, I'm gonna shoot another question over to you. As we look to more telemedicine visits in the future, how often do you think patients with epilepsy should be encouraged to see a physician in person to get blood draws and check levels with their medicine? Any opinions about that?
So remember, you don't have to come to the doctor's office to get blood drawn. So a lot of the things that we think, oh, you need to come to my office to get this done, can now be done remotely as well. I mean, it's certainly possible for me to order labs in the patient's hometown and have them sent to me electronically. I think that probably I would want to see most patients in person, probably at least every other year if they were well controlled, and probably at least once a year if they were still having seizures. But those visits, are not absolutely necessary. I think it would depend on how the patient is doing and whether they had parts of their exam that needed to be done in person, whether they have a device that needs to be programmed or checked. But so far it's been 6 months almost that we've been doing telemedicine, and I have very few patients where I've said, I absolutely need you to come to the clinic to be seen.
So in other words, make sure that you talk to your neurologist or epileptologist and ask them how many times you should be coming in and what the other options are.
Right.
All right, and Dr. Joshi, since you really touched on some of the technical aspects, how do we get around some of the access to even high-speed Wi-Fi? Has that been discussed during all this, and have patients asked, well, I'd like to do telemedicine, but I just don't have the capability to do so?
So I don't think that we've really got down to, well, what do I do if you don't have Wi-Fi? And that actually has affected us, because in the western slopes of Colorado, there were fires and there wasn't high Wi-Fi. And for a physician like me, I'm like, I don't know how to help there. Sometimes I think, short of saying, well, do you want, one of my patients actually went to a cinema house, which I would not recommend, or to go to Panera because they have Wi-Fi, because I don't think these are private areas to talk about or to show me a rash, maybe, right? I don't want to be undressing the patient in such an area. So I think maybe at a different level, and this brings up a very important issue, would it be possible to leverage that for medical reasons we need Wi-Fi with your carrier, perhaps, to see whether that could be leveraged for the time of the visit. And that's certainly possible to do.
Okay, that makes sense.
Some of my patients have been able to go to their provider's office, and some of them have actually set up sort of Wi-Fi hotspots. So their primary care provider has a room in the clinic where people can come and do visits with another provider. I think this is an area where we could think about how to do kiosks or private areas where people could actually go and pay a small amount of money to have access to Wi-Fi in a private area once COVID is over and there's no social distancing issues. There is a telemedicine government service, and we can provide that information on the epilepsy website, that patients can actually apply to get both a device and a plan for high-speed internet access if they meet certain financial requirements. So there are ways that people can get that access, particularly if they need it for medical reasons.
All right, great information and great insight. Thank you. And at this time, I'm going to have to close our Q&A and move on to our next session. So thank you both very much for being here today. And at this time, we would like to thank our many pioneer sponsors. And don't forget, you can visit with them in the exhibit hall by clicking on the exhibit hall tab. Also, please make sure to answer our epilepsy treatment poll questions, which you can find in the link above the live video. Choose the one answer for each question that is most applicable to you. And again, thank you to SK Life Science for sponsoring our poll. All right, now we're going to move to our next session, which is SUDEP, Knowledge is Power. During this session, we'll learn about sudden unexpected death in epilepsy, or SUDEP. Sally Schaefer will tell us about the Epilepsy Foundation SUDEP Institute and the No SUDEP Now campaign. Dr. Latu will teach us about what SUDEP is and the current research around it. And Victor and Libby Boyce will share their family story and the importance of talking with your doctors about SUDEP. As with the other sessions, it will be followed with Q&A, so please submit your questions using the chat as we move through the session. Our first speaker and moderator for this session is Sally Schaefer, who is the Senior Director of the SUDEP Institute with the Epilepsy Foundation. She brings not only her passion and dedication to this role, but her personal experience as well. Welcome, Sally, and thanks for joining us.
Thanks, John. Thanks for having me, and thanks for everyone for coming today. I am very excited and to be here to share this information with you. Not a very comfortable and easy topic to talk about, but it's one that everyone does need to know about and share with their physician and loved ones and have this conversation. So thank you for being here. And I want to talk a little bit about the SUDEP Institute. And with that, I want to tell you a little bit about the SUDEP Institute. It was developed in 2013 when a father out of Colorado lost his son, and he came to our organization and said, why aren't we talking more about sudden unexpected death from epilepsy, or even loss from epilepsy in other ways, accidents, drownings, and other situations? And the Epilepsy Foundation heard that message and said yes. And so the Epilepsy Foundation created the SUDEP Institute so that we can do these main things here, our strategic areas. We want to create awareness for people living with epilepsy, their families, and medical professionals. We know for everyone that this topic is hard and it's not easy to talk about, but awareness is key, because if you have awareness about sudden unexpected death from epilepsy or death from epilepsy, you can help mitigate your risk or work to mitigate your risk. The other thing that we want to do is educate. We want to provide reliable education about the SUDEP risks, what I just talked about, to empower people. That's really what my goal is. When I came to the Epilepsy Foundation in 2018, my first big event talking with the community was the Pipeline conference that you're at today. And I realized that I needed to create tools. And one of the tools, when I flew home, I thought about was empowering people with epilepsy. You are strong. Your caregivers are strong. You just need the information to ask the right questions and to know more about SUDEP. And so I did create a flyer that's called SUDEP, Knowledge is Power, and it has all the questions that you need to ask your medical professionals to know more. And so that came out of this event, is me coming up with that flyer. And that's what I do, is when I speak nationwide, when there isn't COVID, I try to empower and strengthen people through me and the tools and resources so that you are stronger to have this conversation with those around you. The other very important thing is research. We at the SUDEP Institute drive and support research into the causes and ways to prevent SUDEP. We have a biomarker challenge happening right now to try to find a biomarker into what causes SUDEP so we can alleviate that. We also are having a SUDEP summit with 50 researchers, scientists, and medical professionals from around the world to put into effect a 5-year action plan to end SUDEP. So we really support and drive that research so I'm out of a job. So I'm not here talking about this because that is what is so important. We also offer grief support for those who have lost. This is a free and complimentary service from the Epilepsy Foundation for anyone that has lost someone they love to epilepsy, whether it be SUDEP or some other means. We want to support those people, the caregivers who are left behind, and the community affected by this loss from epilepsy. So those are our strategic areas of the SUDEP Institute. And if we move to the next slide. No SUDEP Now is an initiative that was put together by the SUDEP Institute in partnership with the Cameron Boyce Foundation. I reached out to Libby Boyce after Cameron died, and as you know, Cameron is the Disney star and from California, and I reached out to her as a mother. And I reached out to her not only as the professional that runs the SUDEP Institute, but I reached out as a mother who has lost. You see, I am in this role not only because of my passion for this topic, but that passion is derived from the loss of my own child on Mother's Day 2014. My daughter never woke up. She had a very rare intractable epilepsy, and she died in her sleep. And so when I reached out to Libby, it was as a mom who knew this pain. And Libby and Victor and I, we met, we talked about the SUDEP Institute, our goals, our strategic areas, and what we're trying to achieve. And together, we developed an initiative called No SUDEP Now. And our goals are to bring national and worldwide attention and education to those living with epilepsy, the medical professionals, caregivers, and the general public about SUDEP. We have social media channels. We also have a website. We have developed together a 30-second and 60-second public service announcement, and that has been live on Fox and CNN. Libby, Victor, and I have been together on Good Morning America, as well as the daytime show, The Doctors. And we also had an article on Good Morning America online about mothers who have lost children to epilepsy. Libby, of course, was featured with an article, but there was 5 other mothers that were also featured who have lost their children. And so I am pleased that the Cameron Boyce Foundation has agreed to partner with us on this initiative to raise more awareness and educate everyone with epilepsy and without about the possibility of losing someone they love. Next slide. Now, I am pleased and excited to also introduce Dr. Sam Latu, who is the John P. and Catherine G. McGovern Distinguished University Professor of Neurology at the University of Texas Health Science Center, McGovern Medical School, and Executive Vice Chair of the Department of Neurology. Dr. Latu also serves as Director of the Texas Comprehensive Epilepsy Program. His main research interests are in the mortality of epilepsy and sudden unexpected death in epilepsy, or SUDEP. I am also pleased that Dr. Latu is on our group for the SUDEP Summit for our 5-year action plan. He is very integrated with the Epilepsy Foundation and our efforts. I want to welcome Dr. Latu.
Thank you, Sally, for that very kind introduction. I want to thank you also, and Alison, for putting this session together. It's a very important session, and the SUDEP Institute and the Epilepsy Foundation have played a huge role with their advocacy for the SUDEP mission. And a lot of what I'm going to discuss over the next 10 to 15 minutes is the fruit of those labors. So my remit is to talk about SUDEP research, and in particular, an update as to what is new and where we're heading with our knowledge of SUDEP. It's not going to be overly comprehensive because that would be a very long lecture indeed, but I will talk about some of the stuff that has come out of the Center for SUDEP Research, which is an NIH-funded center without walls for investigating the mechanisms, causes, identification of risk factors, and so forth. So it would help, I think, to talk about a timeline of how things have come about in SUDEP. You'd be interested to know that one of the earliest written accounts of SUDEP actually comes from George Washington's account of what happened to his stepdaughter, Patsy Custis, way back in 1773. She suffered from epilepsy, and she indeed died after a seizure. And George Washington's account of what happened is very similar to what is noted in current descriptions of what happens in SUDEP. So we have to fast forward all the way to 1975 for the actual first comprehensive description of SUDEP in a population with epilepsy. And then we have to move forward to 1997 when the professionals in the epilepsy community actually got together to produce definitions for SUDEP. In 2013 came one of the most important studies carried out in SUDEP so far. It's referred to as the Mortimer study, or the Mortality in Epilepsy Monitoring Unit study, where investigators actually put together retrospectively data from epilepsy monitoring units where patients, while being monitored, had passed away. And this gave us a lot of information as to what happened during the seizure, after the seizure, what happened to breathing, to cardiac function, and so forth. In 2015, and this is the advocacy that I refer to by folks like the Epilepsy Foundation, the Cure Foundation, other patient bodies, where the NIH put together the funding to start a center without walls, specifically for SUDEP. This was a collaboration between 9 different centers for some of the projects, and an additional 6 other centers for some of the other projects, based here in the United States, but also in Europe and the United Kingdom. Now, if you look at the amount of research that has gone into SUDEP, you will see that in 1996, for example, there were a handful of papers that came out on SUDEP research. There's a bit of a blip in 1997. That's the year that the definitions were put together. And in large part, that blip is accounted for by all the discussions that took place around the definitions, because in 1998, not a great deal happened. But you can see happily that in the years since, and again, this is the tremendous amount of work done on the awareness of SUDEP, not only amongst patients, carers, and clinicians, but also in the research community, such that in the year 2018, and it's even more in 2019, there were almost 160 mostly original research papers that were put together in the field. So we know now from monitoring SUDEP cases and near SUDEP cases in the epilepsy monitoring unit that there's a certain pattern to death. After a seizure ends, you can see in the red tracings there, which is EKG, that the heart does all kinds of strange things. It becomes bradycardic, where the heart rate goes down. The heart indeed stops for a period. If this goes on to SUDEP, it doesn't revive. If it's a near miss, then it kind of splutters back to life after a period. And during the same time, strange things happen to breathing too. It's either ineffectual or patients stop breathing completely. And this combination of cardiac dysfunction and breathing dysfunction is sometimes fatal. So what have we learned about breathing, which seems to be so important in determining whether patients suffer from SUDEP or not? And here I refer to one particular phenomenon that's referred to as ictal central apnea. Essentially what this means is that in the middle of a seizure or at the beginning of a seizure, patients stop breathing completely. So is this dangerous? Well, as you can see from this particular diagram, on the x-axis we have the apnea, which is where the patient stopped breathing in terms of seconds of time. And on the y-axis we have oxygen. So what happens to oxygen if a patient stops breathing? Between 94 and 100 is the normal situation. Each of these dots represents a patient with his or her seizure. And as you can see, the longer patients stop breathing, the more the oxygen drops. Happily, as this diagram shows, the vast majority of people during a seizure will stop breathing only for a short period, and the oxygen will only drop by a small amount. But if you look at the bottom right-hand side, you will see a few dots there where the cessation of breathing has gone on for a long period of time, and the oxygen has dropped tremendously. And we believe that this is a situation that predisposes to SUDEP. Now, what is driving this cessation of breathing? And from researchers in the Center of SUDEP Research, we have come to understand that if the seizure spreads to certain parts of the brain that control breathing, then it paralyzes breathing function. And in the brain diagrams, you can see those little dots in red. Those are the areas that control breathing. These are not all the areas, but some of the areas that are important for controlling and modulating breathing. So it stands to reason that if one has seizures that perpetuate in this particular area and go on for a long time, then that will produce prolonged cessation of breathing and possibly a predisposition to death. Now, happily, it turns out that if we modify the way in which these areas behave with the intervention of seizures. So we know this from creating a situation like seizures, where we can actually pass electrical current through these parts of the brain. You can either produce paralysis of breathing, and using different parameters for electrical stimulation, you can actually stimulate breathing. So this opens a window to a brand new area of research, which is where we carry out deep brain stimulation chronically to make sure that breathing continues or indeed is stimulated after seizures, thus preventing cessation of breathing and death because of arrested breathing. So this is work that's currently going on, and the lead investigator who did a lot of the research that I'm talking about was recently given a grant to study this and to see if devices can be produced to do this. Now, there is a different kind of breathing arrest, and this is not during a seizure, but this is arrest of breathing after a seizure. And we believe that the mechanism by which this happens is a little different from what we've just discussed. So again, I repeat that this is arrest of breathing that occurs after a seizure. And this is what was observed in many patients in the famous Mortimus study. So here we come to a very important structure in the brain that we refer to as the brainstem. And this is the part of the brain which in the right-hand diagram is highlighted in the bright orange. So this is the part of the brain that connects the cerebral hemispheres to the spinal cord. It's also the part of the brain that subserves a lot of very important functions that you can see outlined in the verbiage on the right-hand side of that particular diagram. So this is a primitive part of the brain, and I don't mean that in a pejorative sense, but primitive functions that allow survival, such as breathing and cardiac function. The seat of these functions is actually in the brainstem. And a lot of research that's been carried out now and in the recent few years has been to do with what happens to the brainstem during and after seizures. So we've come to understand that this is a very important structure in the pathogenesis of SUDEP. So how do we know this? And so this is a study that came out from the University of Iowa, where patients were given increased concentrations of carbon dioxide to breathe. And to explain this, carbon dioxide is a gas which is produced in the body and which we exhale. If we don't breathe well, the carbon dioxide accumulates in the body, and the natural response of the body is to breathe faster so it expels this excess carbon dioxide. This reflex is something that happens in the brainstem. So what we see in these graphs is that if you increase carbon dioxide, the patient breathes faster, and in the first graph, you see the normal response, where increased carbon dioxide produces increased breathing. What's circled in red is a patient where increasing carbon dioxide did not produce an increase in breathing. And this is similar to what happens to patients who die of SUDEP. And this is indeed the graph of a patient who later went on to die of what we call SUDEP plus. So this is very exciting in highlighting the role of the brainstem, but also a technology by which we might be able to identify risk in the outpatients department. But this highlights the role of the brainstem. What else do we know about the brainstem? We know that there is a very important molecule, a neurotransmitter in the brainstem that we refer to as serotonin. And we have found out from recent research that there's a problem with this particular neurotransmitter in patients who have long-standing epilepsy and who develop the kind of breathing dysfunction that I just spoke about. The cessation of breathing during seizures and the cessation of breathing after seizures. So ictal central apnea and post-convulsive central apnea, there is a problem with serotonin. So what happens is that in general, these folks have lower serotonin levels after seizures. So lower serotonin means disordered breathing. And this is also happening in the brainstem. So a scan of the brain, would that tell you things? So this is a paper that came out a few years ago from CSR researchers who looked at the brains of people who died of SUDEP. And they found, and you can see in those sections there, the areas that are highlighted in red, that's actually the brainstem, that those parts of the brainstem that control breathing and cardiac function are in fact damaged. And we hypothesize, and there is some evidence for this, that patients who've had convulsive seizures in particular for a long period of time, because in each seizure there's a lowering of oxygen levels, that perhaps these parts of the brain become damaged as a result of seizures. There is more recent research which is actually coming to fruition now that shows that we can do this kind of scanning in patients, live patients, where we can spot this kind of problem through functional MRI. So this again highlights the role of the brainstem. Now, this is not just a question of measuring molecules, looking at breathing, and doing imaging, we know from Dr. Thom from University College London, who was one of the CSR researchers, that there's actually a depletion of brain cells that produce serotonin in patients who die of SUDEP. So here what she did was she looked at autopsied brains and looked at the brainstem and found this to be a problem. So we have a full set of information that tells us that the brainstem is one of the main parts of the brain where the problem lies in patients who are at risk of SUDEP. A very important piece of research came from our colleague, Dr. Nobles, from the Baylor College of Medicine, who talked about spreading depression. And this is a phenomenon where after a seizure, there is a wave of dysfunction that travels across the brainstem, shutting down the important structures that subserve breathing and cardiac function. Now, this was shown by Dr. Nobles and subsequently researchers in the Netherlands as well in animals. Whether this happens in humans or not is a question. It does happen in patients who have migraine, for example. You have spreading depression that produces blurring of vision or flashing lights that evolves over a few minutes. So that's the wave. Whether this happens in the brainstem in humans is a question that we ask and so far have not been able to answer. A lot of work has also been done on genetic risk for SUDEP. And on the left-hand side, you can see a whole array of genes that have been suggested to produce SUDEP risk. A lot of that is to do with animal models. We currently have no evidence of a genetic predisposition in humans, and it's difficult because in many cases, we have trouble telling what gene is predisposing to epilepsy and what gene is predisposing to death. We know for certain that SUDEP is probably not familial. So, SUDEP passing from generation to generation is not something that we encounter. But we do know that there are certain genetic disorders where the risk is higher. So Dravet syndrome, for example. And there are other genetic conditions that coexist with epilepsy, like the long QT syndrome. So there is work going on in genetics, but we are currently not able to precisely identify genetic risk. So what about intervention? I spoke about deep brain stimulation. That's very much at a research stage. But the story with serotonin, the neurotransmitter, is interesting because, up and down clinics all over the world, patients are prescribed medications that increase serotonin levels. And here I refer to what are known as SSRIs, or selective serotonin reuptake inhibitors. You would have heard of Prozac and Seroxat and drugs like that. So the question is, do these drugs help? We have good evidence in animals that they do. In humans, we have some evidence, but not enough evidence at the current time where we would be able to run a large-scale clinical trial to prove this. So what I spoke about earlier about the brainstem and breathing dysfunction and serotonin is an encouraging step forward in that direction. You can see here in the bars that there's a distinct difference between what is in light green and dark green. The light green bars are to do with patients who have breathing dysfunction. You can see that their serotonin levels are lower after seizures. So this is something that we are thinking about and undoubtedly will accumulate more evidence either for or against. One of the most encouraging recent pieces of research is this particular paper that came from Dr. Friedman and Dr. Da Vinci's group in New York, where they looked at SUDEP incidences in 3 different areas, in New York City, in San Diego County, and in Maryland. And what they compared was the period between 2009 2012 and the 4 years after that. And what they found was that there was a 28% reduction in reported SUDEP. So this, no doubt, will be repeated in other studies to see if this is indeed a real trend. But if it is, this is extremely reassuring because this tells us that all the work in the last 10, 15, 20 years that bodies like the Epilepsy Foundation and the SUDEP Institute have done into advocacy, in awareness, and awareness not just amongst patients and carers, but professionals themselves, neurologists, internists, and even epileptologists, is perhaps bearing fruit. So this is a very encouraging news and hopefully a real trend that we see up and down the country and in other parts of the world as well. So I'll conclude by saying that SUDEP research is thriving. You can see from the slides that I've shown you that we're much further ahead in the understanding of SUDEP and in SUDEP awareness and many other things compared to just a few years ago. With all the studies that we do in the Epilepsy Monitoring Unit, in particular with breathing and with cardiac function, we're able to fine-tune risk better. And I'm very happy to say that more and more colleagues across the country are beginning to think about monitoring breathing and cardiac function. This is not standard in some epilepsy monitoring units. And not a month goes by without me receiving an email from a colleague somewhere asking for our protocols for monitoring breathing in particular. So all this means that we are close to creating a risk index that identifies risk in individuals, not just in populations, but in individuals. And this sets the stage for clinical trials, for response to treatments, and a bunch of other things. So understanding these processes creates really the means to doing targeted interventions. Awareness of SUDEP and prioritizing seizure freedom, reduction of seizure frequency, this continues to be extremely, extremely important. And so what we're doing today in this particular session is part of that. And here I'll conclude. Thank you.
Thank you so much, Sam, for that really informative talk. We had a lot of great questions come through during your discussion, and we're going to wait for all the questions and answers until after Libby and Victor Boyce come on. So with that, I want to welcome and introduce Libby and Victor Boyce. Libby Boyce holds a degree in social work and has worked for Los Angeles County in healthcare administration for the past 28 years. She is the president of the Cameron Boyce Foundation. She is married to Victor Boyce and is mom to Cameron and Maya Boyce. Victor holds a degree in business and has been self-employed for many years, and he is the vice president of the Cameron Boyce Foundation. So with that, I would like to welcome Libby and Victor.
Hello. Good morning, everybody. It's morning here on the West Coast. We are the parents of Cameron Boyce. Folks may know him as a young actor. For us, he is our beloved son, who we lost over a year ago to SUDEP. I'm going to tell you a little bit about his story and what we've learned since he's passed, what we wish we knew, and what we're doing in the Cameron Boyce Foundation to make a difference. Cameron had his first seizure on New Year's Day when he was 16 years old. He died when he was 20. When he went to the emergency room that day, we were told by the doctor that he had a seizure, and that very often people have a free seizure, one seizure and no more ever in their lifetime. But that if he had another seizure, he would be considered to have epilepsy. That was the extent of that visit. We went about our business, and about 9 months later, Cameron had another seizure. All of his seizures were in his sleep, I should mention. We went back to the neurologist. He had an EEG, he had a strobe test. The neurologist talked to him and basically explained to us that at that point, because he had had his second seizure, that he was considered to have epilepsy and he should be medicated. So he started Keppra at that time. Somewhere in there, it's all a blur, he had a third seizure. And then he had his fourth seizure, all of which were about 9 months apart to a year apart. During that fourth seizure, he also had like a stomach virus and he had been pretty dehydrated. And we found out at that time that he hadn't been taking his medication correctly. So between the time that he had his fourth seizure and his fifth seizure, which is the time that he died, he was religiously taking his medicine. He was learning more about epilepsy, and he was owning it a little more and taking responsibility for it more. And 13 months later, after his fourth seizure, he had his final seizure, which is the evening when he died. The night before, we had all gone to dinner. We had a lovely dinner, my family, my daughter, my son, and my husband. There was an earthquake. We all held on to the table and giggled. We dropped him off at his new home. We talked about how blessed we were. Our son had a home, was doing well. He was happy. He was amazing. Had an amazing family. We have a village like nobody's business. And he died in his sleep that night at about 2 a.m. The coroner's report told us that he died of SUDEP, something we had never heard of. We knew he died from that seizure because we knew there was no other anything that it could be. We knew our son so well. We were a very, very, very close family and continue to be. What we have learned from that time on, 2 days later after Cameron died, we started the Cameron Boyce Foundation. And we realized very quickly that we needed to learn about epilepsy because we did not have enough information. We were not armed with information. The doctors did not tell us enough. All of this may have not saved his life, but I feel like you have to be armed with information. You have to advocate for yourself. And doctors need to be more forthcoming about the fact that epilepsy can be fatal and that there are things that you can do to reduce your risk. We learned, obviously, there's 40 different types of epilepsy. It's important to know what type you have because how do you treat it if you don't know exactly what type of epilepsy you have? We have also been very surprised at the fact that epilepsy is not talked about that much. And it's the most common disease that's talked about the least. Think about other diseases, Parkinson's, cancer. I mean, you could go on and people don't talk about epilepsy. So we have a platform. We are taking Cameron's voice through us to do all that we can do through the Cameron Boyce Foundation, through our relationships a little bit with people in Hollywood, through our village of people out there, to really learn as much as we can and figure out how we can contribute in a compelling way to the study of SUDEP. We would like it to end. We would like no other parent to ever go through this. And that's basically our goal. The Cameron Boyce Foundation is working on exploring all kinds of ways that we can partner on research into epilepsy and SUDEP. We have been fortunate enough to be able to receive our own 501c3 this year and to be able to bring in donations that we can contribute and that we can continue this work in the name of our son, that his death is not in vain. It's all for the love of him and for the love of others who are having to live with this disease. Cameron didn't have a lot of seizures, so it was hard to know what to control. If you're not having seizures, they don't change your medicine because you're not having seizures. And just like the doctor just said, the goal is not to have seizures. We're also doing a lot of other things in the Cameron Boyce Foundation to honor Cameron, things that he was very interested. He was a very philanthropic young man. He was an incredible individual, and he was very interested in youth and giving them alternatives to violence and alternatives to negativity. He was the kindest person you ever want to meet, and we're just carrying that forward as best we can in his honor. Is there anything you want to share?
Yeah, I would like to thank the doctor because I learned a lot in that segment that he just gave. Some of it I knew a little bit, but he clarified it very, very well. And the whole thing about the brain stem cell and the breathing, I know that's exactly what happened to my son. Like my wife said, our goal with our foundation is to really help drive the research to help people like the doctor and all the researchers and all the scientists and doctors to really get to a cure and get to full understanding, so that no one has to go through what we went through. And I just really appreciate the efforts of the people who are really smart, and we want to help them in our own way, and that way is going to be research dollars. I don't know what else to say. Sally?
Thank you, Libby and Victor, for sharing your story. I know it's just a little over a year, but yet that seems like a lifetime, but yet like yesterday. My loss is 6 years ago, and just hearing you, I feel it, and I am so thankful that you're here today and that you're able to share and give your perspective and your thoughts to others that are listening today. So thank you so much. I know this is not easy, so I appreciate you partnering with us on No SUDEP Now, as well as being here today for everyone. As you can see, all of the speakers are here on the stage, and we're going to move to the Q&A that we have. So we're going to start with, if you have any questions, please type them in the chat box. We want to start with Sam, or Dr. Latu. I'm so sorry. So used to calling you Sam. What clinical tests, if any, can be done to maybe check for SUDEP? Is there any type of clinical testing that can be done?
That's a great question.
A lot of the information that we believe to be important for SUDEP risk comes just from clinical encounters in the clinic, where we gauge things like the presence of convulsive seizures, which is a big risk factor, the number of convulsive seizures that occur in a given period of time. That's an additional risk factor. So this kind of risk can be gauged in the clinic itself. Fine-tuning risk, which is what I spoke about a little bit, we are now getting more and more evidence that in some seizures, there may be clues that fine-tune this risk beyond just convulsive seizure frequency. And that kind of information we get in the epilepsy monitoring unit. So assessment in the epilepsy monitoring unit, particularly for patients who have, treatment-resistant epilepsy. Of course, that's the population in which we see the highest SUDEP incidence. That's very important. So this assessment in the epilepsy monitoring unit, and alongside the assessment of the epilepsy, assessment of what happens to breathing function and cardiac rhythm function. These things are very important. We're not quite at a pass yet where we can do brain scans and things like that in the clinical setting to determine risk. But I believe that day is not too far away.
Hey, Sally, can I add something which is based on what the doctor just said? I would keep a log because one thing, like, we didn't really know until later that he had, it was clearly grand mal, like tonic, clonic, whatever you call them. He had severe, and the doctors thought he had petit mal. We realized, like, later, because he had so few, I would suggest that parents keep a log and note everything down, like exactly what happens, because you quickly forget that stuff. And, you know, you have to be your own advocate. So you've got to write everything down as much as you can when you see the doctor, so you can feed that kind of information to them.
Great advice. Great advice. Parents keep logs, or family or caregivers, whoever's there with the loved one, as well as taking videos so the doctors can see what that seizure looks like. Wonderful advice. Another question I have for Libby and Victor is, we know that Cameron lived his best life. He did what he loved. He did not let epilepsy stop him. And that's so inspiring that he just did what he loved, even with that epilepsy diagnosis. However, knowing what you know now, beyond this log advice that you just gave, what advice would you give to parents with a child with epilepsy, or even a person living with epilepsy?
I really feel like we did not get enough information from the doctor, and because he just had so few you know, seizures, we sort of minimized it, and that's kind of what he wanted to do. And if I could do it over again, I don't know that we could have saved him, but I would say I would be much more assertive with doctor visits. Like, we weren't even told to come back. So we just saw a presentation from another doctor who said I'd see them once a year, and I'd be in touch more often. We weren't even doing that. So, you know, we weren't given the full story, and we have worked with our medical provider to say, hey, you could do better. But I would say across the board, like, you have to arm your patients. And unfortunately, parents have to be their own best advocate, and they have to just study it and ask questions and keep that journal. And obviously we learned all about hydration and sleep and all of that, which, you know, Cameron had learned as well and was doing. But yes, he was somebody who really did so much in his 20 years. We have no regrets about his life. He was incredible. And, you know, it's really just push it further. Learn as much as you can. Reduce seizures. You don't want seizures. So if you're having breakthrough seizures, you need to get with your healthcare provider, and you need to discuss, and you need to feel comfortable with your healthcare provider. I wasn't crazy about our doctor, and I didn't change the doctor, and I regret that.
That's some advice that I always give to people that come to me as well. If you're not comfortable, or you don't feel like you're getting the answers that you want or need, you know, think about of changing and finding somebody that might fit you or with your comfort level. We might have time for one or two more questions. Dr. Latu, I know that SUDEP can occur at any age. This is one of the questions that came in, but is it more common in children than adults? What are we looking at as far as individuals who have succumbed to SUDEP?
We believe that the risk as such is the same in children as it is in adults. If we look at absolute numbers of deaths, they are less in children, but this is probably because deaths in children per se are not so common. But in terms of risk, absolutely, probably the same as in children as in adults. And I just wanted to add, you know, Mrs. Boyce, what you said is absolutely true. And we have, you know, good peer-reviewed scientific literature to say that we as neurologists, you know, we haven't got this right. We either don't talk about it, and there are papers from as recently as 2014 to prove this, or we are deficient in that knowledge. And, you know, a lot of efforts have been made to increase SUDEP awareness. Sessions like this, similar sessions that we have in a professional conference setting, these hopefully have begun to address this. And you saw that in the statistics of that recent paper that shows a reduction in SUDEP risk. I personally, no resident and no fellow goes through our program without learning about SUDEP and SUDEP risk. There's a lot of work to be done. And I deeply, deeply regret the experience that you guys had. But you are quite right. We're not there yet.
So we're going to close up.
I'm sorry. I just want to say I really appreciate him acknowledging that, because we kind of feel like it's been, even after the fact, it's still kind of swept under the rug. The fact that the information is not out there is just not sufficient, and we could have done better. And it's a horrible burden to bear. You want to do everything for your child or your loved one. Everyone does, and you have to have help, and you have to have the information, and it just can't be glossed over like it was for us. And I hope that everybody doesn't have that same situation. I'm sure there's better and worse, and just like anything in life. But for us, it was insufficient, and we had a really horrible outcome as a result. And we just don't want that for anybody.
With that said, one last question before we close up today. What kind of response, we're just talking about awareness and everything like that. Libby and Victor, what kind of response have you gotten from the epilepsy community regarding the No SUDEP Now campaign and initiative?
Tremendous. Because, we're nobodies, but our son was known globally. And because of his notoriety and because he's so well liked, the response has been tremendously positive, and people are saying, "Oh my God, I have epilepsy. I didn't know about Cameron and or my mom or my cousin or my brother, and we don't talk about it, but now we feel more comfortable, and we're seeking help, and we want to help." And donations have been good, and it's just been like mind blowing for us. But we never thought we'd be in this position. We didn't know anything about it. Now we're running some foundation dedicated to it, and it's like, wow. And we're glad to be impactful in that way. So the response has been overwhelmingly positive.
We didn't even know 1 in 26 have epilepsy.
No.
But we started wondering, as soon as Cameron died, all these people came out of the woodwork to tell us that they had it, or somebody in their family.
We had no clue how common it was. And it's just been, an unfortunate but thorough learning experience for us. And just like today, I learned a lot from the doctor today. And it's just been every day we learn more and more. And, we hope to get to a place where we can, like Sally says, come to a cure.
I've also learned that SUDEP is way underreported. No doubt in my mind that it is way underreported. And just I have been somebody who's wanted to reach out to other people who have lost children, because there's a certain support that we can provide each other that not even my BFF can provide to me. I've been surprised, like out of 20 people I've talked to, 3 or 4 had children that died of SUDEP, and it wasn't necessarily through the Epilepsy Foundation grief group. So I've been just shocked, and I believe it's incredibly underreported.
And we could talk about that for a whole nother session. That is also something the SUDEP Institute works on, is working with our medical examiners to make sure that they are reporting. You heard from Dr. Latu about Dr. Friedman and Dr. Davinsky's work in that area as well. So we have unfortunately run out of time. I want to thank you all again, and our speakers, Dr. Latu, Victor, and Libby Boyce, for being here today. Don't forget, you can visit them in the exhibit hall by clicking Exhibit Hall tab. And now we're going to take a 10-minute break before our next session. And we really, again, appreciate you for being here and listening to this really hard topic. But hopefully we've empowered you today with information and tools and resources so that you can do more and hopefully have these conversations with those that you love and your medical professionals. Thank you so much.
We are SK Life Science. We explore the complex mysteries of the brain to find answers for patients, caregivers, and healthcare professionals around the world. The SK Life Science family is passionate about improving the lives of people with epilepsy. Together, we work toward this goal every day.
We are here to help the epilepsy community and support the efforts of the Epilepsy Foundation.
For more than 50 years, the Epilepsy Foundation has been fighting for the 3.4 million people living with epilepsy in the U.S.
At SK Life Science, we share in the Foundation's sense of urgency.
We're working to help increase awareness, innovation, and opportunities for community connection.
We know we are stronger together, and we're dedicated in the fight to end epilepsy.
At Neurologist, we take this responsibility to the epilepsy community very seriously. It's not about just bringing a product to the market, it's about bringing other programs and support materials to help better manage epilepsy. And so we will be working with patients, with their caregivers, with patient advocacy organizations, with nurses, physicians, other healthcare providers, through programs like My Neurologist, through other printed materials, help better manage and be prepared for seizure emergencies and look for opportunities to help enhance the management of epilepsy, because that's just part of the responsibility that we have.
Danny Stanton spent many days on this field, but just before his 5th birthday, he had a seizure and died from sudden unexpected death in epilepsy. We started the Danny Did Foundation as a promise to Danny to protect other families who face seizures. Keeping that promise would make our son happy.
Connect with us at DannyDid.org to learn more and to donate.
And enjoy your life just like Danny did.
At Synovian, we are focused on creating innovative therapies that help transform lives. We are proud to support the Epilepsy Foundation's Pipeline Conference as we believe scientific exchange is vital to finding treatment paths to improve the lives of patients. We look forward to seeing the latest in R&D at every stage and connecting with the epilepsy community.
Hi everyone and welcome back. Now it's time for our next session, Cannabidiol, Making Informed Choices. During this session, we'll hear from Freeman and Leanna about their family's journey with epilepsy and cannabidiol. We'll also learn about the known benefits and risks of cannabidiol and the differences between FDA-approved and generic products from Dr. Patel. And Abby will share what's new and what's coming next as it relates to advocacy regarding the subject. As with the other sessions, it will be followed with live Q&A, so please submit your questions using the chat. Now I'm excited to welcome Freeman and Leanna Dando. Leanna is a board member for the Epilepsy Foundation Central and South Texas, and Freeman is currently the 2020 through 2021 Teen Speak Up representative from Central and South Texas. Welcome, Freeman and Leanna. It's great to have you here today.
Thank you. Like I said, you said, my name is Leanna Dando, and I am here today with my son, Freeman. It's our privilege to be speaking today on behalf of the Epilepsy Foundation and to share our personal journey with epilepsy and the path that led us to medical CBD and how it's impacted our family today. Freeman has overcome a lot of obstacles and has worked very hard to get to where he is at today. As you mentioned, he is currently the Texas Central and South Texas Teen Speak Up rep, working hard and doing his part to raise advocacy and awareness for himself and others living with epilepsy. So having said that, I will turn this over to Freeman, who will share his story and what he's been up to these days.
Hi, as my mother said, I'm Freeman Dando, and I have refractory epilepsy. My first known seizure was on June 30th, 2008. I was 2 years and 9 months old at the time. Since then, I've been living with seizures for 12 years now. Over the years, my epilepsy has gone really out of control, pausing my life each time. I've had thousands of seizures, countless trips to hospitals all over the country, and I've had every test, image, and scan possible to see if I'd be a good surgical candidate. And I've used more medicine than I can count, failing and having really bad side effects that would make me sick. About 2 years ago, my epilepsy got really bad and I started having more seizures than I could count each day. I was unable to go to school, hang out with my friends, and even play sports. My medications weren't helping me, and we felt like we were out of options. And then my parents talked to my neurologist about medical CBD. And with the support and encouragement of our neurologist, we decided to try it. In the span of about 4 days, I went from having countless seizures to zero. To me, medical CBD has made the biggest difference in my life, and because of it, I was able to go back to school, see my friends again, and even join the cross-country team. And that would eventually get me to the district meet that year. I also finished the school year participating in the National Junior Honor Society, and I'm now almost 15 and a freshman at Lake Travis High School, where I'm taking AP and biomed classes. And I continue to run cross country. I'm grateful for my continued stability and to hang out with my friends and play video games and work on music in my free time. I still have seizures every little while I'm sleeping, but in my opinion, medical CBD saved my life and is my miracle drug. To share a little bit more about TSU, Teens Speak Up, I was nominated this year to be the TSU representative for Central Texas. The day I heard that I was invited to participate in TSU was like any other day at first. I got home from school, started on my homework, but then my mom came in with the great news. I was even more excited to be part of it, so we flew to Washington, D.C., and I started classes. I attended meetings and learned about important bills related to epilepsy, what to do, what to say, and on Capitol Hill Day, my mom and I talked to government officials such as Representative Roger Williams, Senator John Cornyn, and Senator Ted Cruz. The bill I spoke most about was safe and legal access to medical CBD and expanding cannabis research federally. I felt great sharing my story and hope that my voice was heard and will have an impact. What decision makers really need to understand is that not all pharmaceuticals are bad for you, and that CBD is a plant-based solution and is making a difference in my life. It was also nice to meet other teens like me and to hear their stories as well. I would also like to talk about the dispensary where I get my prescription CBD. It's called Compassionate Cultivation. I've taken a tour there and it's a pretty cool facility. I know that every time I get a new bottle of oil, it'll be the exact formulation, same amount, same smell, everything. When I take my other medications, me and my parents have to worry about which lab it came from because I may need the exact formulation. I'm very sensitive to any change, so my parents take great relief in knowing that this medication will always be the same. When medical CBD was first prescribed in Texas, it was only for patients with certain kinds of epilepsy. But in 2019, the state of Texas expanded the Compassionate Use Act, House Bill 3703, to allow more people with conditions to have access to CBD. Because of my success story, I was given an opportunity to speak to legislators on behalf of the bill and to share my story with them. I was nervous at first, but as my work on my speech progressed, I realized how important it was. When the day came to give my speech, we went to the Texas Capitol, and then when the time came, I sat down and almost completely forgot my speech. But as I sat there listening to other families share their stories, instead of trying to remember it, I just spoke from my heart. With the help of my testimony, the bill ended up getting passed, and as time progressed, I would get to do things like photo shoots for commercials and papers, and I've even been heard on the radio too. Pretty cool. It's my great hope that lawmakers will understand everywhere that this works and that more research is crucial. And I hope that hearing my story today will encourage others to consider CBD as a medical option. Thank you for your time.
Yeah, and good job, Freeman. To quickly add to Freeman's story, so many pharma meds, I'm sure with a lot of other patients living with epilepsy, people living with epilepsy, they've made him so very sick and have had some pretty terrible side effects. You know, it's been a balance trying to find seizure control and a medication that he can live with and function day to day. And a lot of those medications weren't working for him. And so we were a bit apprehensive in the beginning to consider medical CBD, but we really did feel like we were out of pharmaceutical options for him. Over 12 years, we've tried pretty much everything. And since then, he's been on CBD oil for about 2 years now. He's had no side effects from it, and it's been the most effective medication for him. He still does take other pharmaceutical meds, but we've been able to get down on some of those because the CBD has worked so well for him. And we all know that epilepsy is not a one size fits all, and medications, people react very, very differently to the same medication. So if you've ever found that you're in the situation that we were in, where we really did feel like we were out of options and we were very scared, we would encourage you to try medical CBD and work with your
Thank you, Freeman and Leanna, for sharing your family's journey with us and for the impact you are making in Texas as well as nationally. Now I'd like to welcome our next speaker, Dr. Anup Patel, who is board certified in neurology with special qualifications in child neurology. In addition, he is board certified in epilepsy and clinical neuropsychology. He is the president-elect for the Child Neurology Foundation. He is the section chief of neurology and associate medical director for quality improvement at Nationwide Hospital, Children's Hospital. Please welcome Dr. Patel.
Thank you so much for having me. Today I'm going to talk a little bit about CBD, and if I could get my slides, I don't see them. Perfect. All right, so I want to first say thanks to Freeman and his family for that wonderful presentation. Freeman, that's an amazingly great story, and I'm really happy to hear the success that you've had. It's really stories like that that keep us going in this field, and so it's a great way to kick off this portion of the event today. I'm going to try this virtual clicker thing. There you go. All right, that's who I am. My disclosures. When we talk about CBD, I really want to start with marijuana. And marijuana is a plant, as most people know, but it's mostly this strain called Cannabis sativa. The other one is Cannabis indica, but it's made out of a lot of compounds. And CBD is just one of those compounds that is part of this amazing plant. The one that used to be more popular was the THC, which is the part of the plant or the compound that allows the high to occur. So we call that the psychoactive properties. And so that's really important terminology that we're going to be talking about. And there's some other terms that are listed here, but we're really not going to focus too much about that today. The one we're really going to focus on is cannabidiol, or CBD. It is a very prominent portion of the plant. And what's nice about that is it allows us to be able to look at or extract that from the different strains of the plant, the base plant marijuana. As many know, there is an FDA-approved product called Epidiolex that is a mostly purified version of CBD oil, and that's now available through prescription. And we'll talk a little bit about those studies and also compare that to some of the other products that are out there. But because this gets confusing in the lay communities, I'm sure you guys have heard all these different terms. They're kind of used interchangeably. They're sometimes misinterpreted, and it really was a popular point of topic that CBD was used in almost anything. I say this kind of in a joke that until COVID, it was the primary topic of the medical world, at least in my world. And then, of course, there's use of different type products for different kinds of illnesses or situations, and we'll go through some of that. And really, hopefully, by the end of today, you'll have a better understanding, at least, of what we're dealing with or what you could potentially get. But let's talk about how safe and effective it is. And obviously, we're going to focus in the world of epilepsy. To be honest with you, majority of the studies have been done in epilepsy, and there's really not great medical literature that we'd consider sound and robust that would help us understand the potential benefits or use of CBD in other disease states. To do this, I really want to go back to some statistics and really have some definitions set as we try to interpret these studies. One of the things I really try to teach is knowledge, meaning that the more knowledge you are armed with, the more you can understand the information. But it's confusing. There's a lot of studies out there. They always use different statistics. But the big ones that I want to focus on are these. Okay, so the median. The median is like the middle of a sorted list of numbers. So, if I have a bunch of numbers, I look for the one that's right in the middle, and that's the median. And that is important because that's what the FDA uses as a benchmark to determine whether they're going to approve a medication to treat diseases here in the United States. So we in the epilepsy community use this benchmark when we are trying to do some of the studies around CBD for that reason. Now, the mean is something that we're mostly familiar with. It's the average of the numbers that are there. So it's like a calculated number of the average. And then, so sometimes people will report that in the studies, and that's really translates to the average percent reduction number for patients in the study. Where the responder rate is really those achieving 50% or greater reduction in seizure frequency from where they started. And in Europe, that's what they use for approval. So those are important things I want to keep you guys up to date on as we kind of go through some of these studies. All right, well, we all started back, and the journey is a story in itself, I'll tell you. My friend, colleague Orrin Davinsky and a bunch of great people got together, and then it kind of expanded, and a lot of us started to do compassionate use program for the use of this plant-based product. And what we then learned was, okay, let's publish it and really see if we can help learn more about where potentially this medication could be useful. And what we learned from our original study, and it was open label, which means that, there was no control group. Everybody got the medication or the oil. And what we saw about them is like a larger percent were having Dravet or Lennox-Gastaut syndrome. Now, to get into this study, you had to have treatment-resistant or intractable epilepsy. So, it was since those are two of the more common ones, it's not surprising that you expected to see those two rise to the top in that sense. And really, we wanted to see, okay, is this safe and is this effective? Because that's really important. Well, from a safety standpoint, what we saw, and is very commonly seen in other studies that have come since that we'll talk a little bit about, is the number one in about 25% of the patients, they were tired. And that could be a combination of them and other anti-seizure medicines that they're potentially, having some interactions with, which we'll talk about. Decreased appetite, diarrhea, and fatigue. The diarrhea is an important one because this is an oil-based product, and therefore the more oil you get, the more it can potentially lead to adverse events like diarrhea. So that's an important thing. And then only about 3% of patients stopped it because of an adverse event. Now, in this study, we looked at median monthly seizure frequency. So at the beginning, if you took all these patients, it was about 30. And then during that 12-week period of treatment, we saw it go down to 15.8. So again, the median monthly seizure frequency is what we reported here. So then we've obviously continued to watch these children and adults. And what's nice is that, we had over 600 patients. 76% of those stayed on this medication, which is a pretty high number, and we're really excited about. And when you look at the seizure reductions, we didn't see a drop off. So if you compare those at 12 weeks and then also at 96 weeks, it was still having about the same, 51 versus 48% reduction in median monthly seizures. So that's really important because there didn't seem to be a drop off. With some anti-seizure treatment, we see what's called a honeymoon period, where for the beginning of the exposure to the medication, things and people do well on it, but then over time that drops off, and we did not see that here, which was very encouraging. And the other big important thing is when we look at responder rate. So again, that endpoint that the Europeans look at for approval, it was still pretty maintained at 96 weeks, and it was good. So we saw, the 50% responder rate was 49%. So how does that translate? Meaning 49% of the patients in this open label study had at least a 50% or more reduction in their seizures. So that was at 96 weeks. So good, encouraging info. But the story doesn't stop there, because we really wanted to know, okay, what happened to those people who didn't take or didn't stay on the medicine? And really about 15% was because it just didn't work. And, like any other treatment, if it doesn't work, you're not going to continue it. But only 5% stopped because of a side effect that they weren't really willing or couldn't tolerate. And of those, the biggest one was the diarrhea. I mean, it can be pretty bad. And then the tiredness. Rare overall, but those that have it, that can be an issue. Now, as far as where we went with that next, well, remember I told you that there was some, many of the patients had either Dravet or Lennox-Gastaut. So we thought, well, why don't we look at that in the gold standard manner that we do in our epilepsy community or any other medical community? And that's called randomized, double-blind, placebo-controlled study, meaning that we, as investigators, had no idea if the kid or adult was getting the medication or placebo, and same thing with the child or the patient, and the caregivers had no idea either. So we enrolled kids between 2 and 18, and really we wanted to look at, again, how well they did from an efficacy or, how well the medication worked, and then a safety profile. And what we saw was really encouraging. We saw that the median reduction in convulsive seizures went from 39% to 13% as you compare that to the placebo. So in this study, we saw, okay, those that got the medicine, their seizures went down. They had a median seizure reduction of 39%. And then in the placebo group, it was only 13%. And the responder rate, so again, 50% or more reduction of seizures was 45%. So really encouraging. The side effect profile, as expected, was higher in the treatment group versus the placebo group, but not significantly different, or not so different. I mean, 78% versus 90%. And then we didn't think that major adverse events were related to the treatment part of the medication. In Lennox-Gastaut syndrome, we saw something really similar. And now the good thing with Lennox-Gastaut is this time we looked at different study or different dosing parameters. So there was that placebo group, which again is very important for any study. Then we also looked at a lower dose group, which is the 10 milligram per kilogram per day group, and then the 20 milligram per kilogram per day. Now, what we saw was those that got the higher dose did a little bit better, tended to do a little bit better, but those in the lower dosing range still had a statistically significant difference when you compare it to the placebo. So what does that translate into is that some people do not need to go up on their dosing for CBD, and a lower dose, therefore less oil, can be effective. What we also saw was that the difference, meaning that when did we see those that got the medication do better than those that didn't? That was actually within the first month of the treatment. So early on, you're going to know, or based on these studies, know if the medication is going to work, if it's dosed and properly. And that was really sustained for the rest of the trial that we looked at. And I'll cover some long-term stuff as it relates to this. Well, what did that happen? Well, the story goes that obviously history was made. History meaning that the fact that the FDA, for the first time in human history, approved a marijuana-based product for the treatment of disease in the United States of America. It was a huge effort, but it was really worth it. And now the FDA approval reads that it's for seizures seen in Dravet, Lennox-Gastaut, and now tuberous sclerosis for anybody 1 and older. I often get the question, is it approved for adults? Yeah, it's over the age of 1, but there's no endpoint. So, I mean, it's all adults and all, mostly children greater than the age of 1. You don't need a special license. You don't have to be a part of a certain program. You can use your regular medical license to write these prescriptions, and it's available. And then now it's obviously available in all 50 states because it's an FDA-approved product. So if you do happen to live in a state where this is very difficult, then, obviously this is treated like any other medication like Keppra or Briviact or, any of those other ones, topiramate, et cetera. And what we've now looked at is long-term data. So we're getting ready to look at publishing that. We're going to present an abstract at this upcoming virtual American Epilepsy Society meeting. And really what we've shown is the efficacy, meaning that kids and adults who stayed on the medication continue to do well. And we haven't learned any new side effects emerging, which is a very important thing. When you look at new treatments, you don't have a lot of long-term data or information. So now that we do, it's great to say that there's nothing new that we're learning as far as bad side effects, and that's an important concept. Let's shift gears. So what are vernacular CBD products? And so those are a term you'll hear out there, and those are maybe things that are available in dispensaries or online stores, even Amazon.com. They are not FDA approved, so they tend not to be as regulated or tested regularly. Some programs in the state of Texas, like Freeman was mentioning, there are certain cultivation sites and test or in labs and distribution sites that do some good testing and publish all that. And so it's not universal in that sense, but the majority don't have the same rigor of the testing the FDA requires. But one important thing to keep in mind, and this is an important study out of California, that they actually then took a bunch of these from dispensaries and tested them. And what they learned was that many of these were not making the grade. So the claim was that these were purified CBD products. And when they actually tested, only 1 in 5 actually could back that up. And a lot of the inaccurate labeling was because of the concentration of CBD, but also because of pesticides, bacteria, and processing chemicals that were part of the oil or the products that were being sold. It is really hard to take CBD out of a cannabis plant and isolate it. One of the things I always say about marijuana is it's a sponge plant, meaning it grabs a lot of what's coming from the dirt into the actual plant. And that's why you see this difficulty with contamination from pesticides, et cetera. So it's important to keep that in mind. Remember, natural's a label. You know, I always put these up in a lot of presentations because it's kind of a joke, right? Say, well, I want something that's natural. You know, CBD is not natural in the sense of safety. So don't equate natural to safe. There's not the same things because CBD or anything within marijuana is broken down in your liver. And just like any other medication, if it's broken down in your liver, can have obviously side effects and drug-to-drug interactions. And that's true about any CBD product. So that's not just isolated to the FDA-approved product. That's true of anything that's out there that has CBD or other marijuana compounds. So with that, I want to say thank you. I want to say thank you to the Epilepsy Foundation for having me today and for putting on this extremely wonderful virtual conference. I was listening earlier to Cameron Boyce's family, and I want to say thank you to them and to Sally, my dear friend, for the work they're doing on SUDEP, such an important topic in epilepsy that we must do a better job of educating our patients and families who have epilepsy. So thank you so much. I'll turn it back over to John.
Thank you so much for an informative talk, Dr. Patel. This is clearly an area where there is a lot of interest in our community. So our last speaker for this session is my colleague, Abby Rudabush, the Senior Manager of Government Relations and Advocacy at the Epilepsy Foundation. She manages various state and federal legislative issues, including the Seizure Safe Schools Act and access to care issues like medical cannabis and CBD. Welcome, Abby, and thanks for joining us.
Thanks so much, John. So we've heard a little bit from Dr. Patel about the medical side of cannabis and CBD, but this is also a policy area that is pretty complicated because it is ever evolving. I mean, if you just think of even in the past 5-10 years, how much the law and what we know about medical cannabis and CBD has changed. So there is a lot going on in this area. We can start with, just to give everyone a background on the position of the Epilepsy Foundation when it comes to medical cannabis and million individuals living with epilepsy and seizures in the United States. Of those 3.4 million, 1/3 or over 1 million live with uncontrolled seizures despite available treatment options. So we're committed to supporting physician-directed care and to exploring and advocating for all potential treatment options for epilepsy, which do include CBD and medical cannabis. We support the safe and legal access to medical cannabis and CBD if an individual and their healthcare team feel the benefits outweigh the risks. So it's important to note here, and Dr. Patel talked about it too, but as with any other treatment option, this is something that should not be DIY, do yourself, and as with everything, your physician should be involved in that. To start us off with just some guiding terms as we go through the legal landscape and what the Epilepsy Foundation is trying to do, we'll just start with, so state law. This comes in the form of medical CBD, medical cannabis, or adult use recreational programs. So the state is legalizing cannabis and or CBD on some level. This applies to activities that solely happen within the border of the state. So if you are from Illinois, for example, where adult use is legal, that law doesn't follow you. So it doesn't, you have to follow the rules of the state that you're in. Current Department of Justice policy declines to prosecute this behavior. but this could change at any moment. So we're kind of relying on the word of the federal government here right now, that as long as you are following the law within your state, you should be fine. Then we go to federal law, which generally applies when you either break the state law, then the federal government can come in, and this applies to anybody using medical cannabis or CBD, as well as the actual state program itself. And this also applies when you cross state lines, which does include mailing things or if you buy anything online. In 2018, Congress passed the Farm Bill, which reclassified hemp-derived CBD. So that becomes its sort of own category separate from the medical cannabis, adult use, recreational cannabis laws, just to, of course, make things a little more complicated on all of us. So now hemp is defined as the cannabis plant with no more than 0.3% THC by dry weight. So products that are made from this, as well as the hemp plant itself, are legal federally. However, this does not mean that all CBD or any CBD is legal federally. So anything with more than 0.3% THC by dry weight may be legal on the state level through a medical cannabis or recreational cannabis program, but it is still Schedule I on the federal level, which means that it is still illegal on the federal level. The Controlled Substance Act classifies different substances based on how addictive it is and whether there's any medical necessity or use for it. And so Schedule I is high potential for abuse and no medical benefit from it. So that is how the federal government has cannabis classified right now. To dive a little deeper into state law, again, this governs what you do when you're inside the border of a state. As you can see here in this map, which is also available on our advocacy website, advocacy.epilepsy.com. This shows the landscape of different laws throughout the country. So all of the green states are where it is legal recreationally for adults 21 years of age or older. The yellow states are where there is some sort of medical cannabis program. However, this is different from state to state because the states set these programs up themselves. So the rules of the New York medical cannabis program are not the same as the rules of the Arizona medical cannabis program, and so on. And then we have the blue states, which are where some kind of medical CBD is allowed. And again, this is different from state to state, including what conditions are eligible for this program. And then the gray states are where there has been no action so far, and it is still illegal both on the medical side and the recreational side. So, it's your responsibility for the state that you're in to understand the intricacies of the law and how to comply with the law in your state. And again, this is something that you should be discussing with your physician, and the physician should be brought in as you are thinking about exploring this option. At the Foundation, as I said earlier, we advocate for safe, legal, and meaningful access to medical cannabis programs so that individuals and their healthcare team have the ability to choose which treatment option, including medical cannabis and CBD, may be right for them. So at the Foundation, one of my jobs is keeping track of legislation through all 50 states. We look at what the programs allow, what conditions are qualifying conditions under the program, and what our goal is to make sure that individuals living with epilepsy and seizures in the state have this option in a way that they can actually get meaningful access to it if it's something that they and their healthcare team feel is the right option for them. It's important to note that this is an ever-evolving policy area. There are bills being introduced in states all the time. and changes being made and discussed to these programs. Many legislatures are considering bills in the coming years. And one thing that is important to note for anybody who wants to get involved for advocating for safe, legal, meaningful access to medical cannabis is there is an election coming up in November in many states. Not a ton, but there are a handful of states that do have active ballot measures, which would either legalize a medical cannabis program or make other changes to the law. So, you know, it's important before you go to vote in November, look up what ballot measures are available for you to vote on and do your research, which is generally good to do, a good civic duty to follow anyway, but this is an area that's important with the election coming up that as you go to vote, you can have a say at the ballot box in what kind of cannabis laws are active in your state. So as I said, this all governs what happens when you are inside a state, but there is a whole nother area of law that applies as well, and that is federal law. As I mentioned, cannabis is Schedule 1, which by definition means there's no acceptable medical use and there's a high potential for abuse. So this also makes doing medical research difficult. So on the federal side, what we have are two separate classifications for CBD. CBD is not sort of one size fits all under federal law, which is again where this just all kind of gets more complicated as individuals and their healthcare teams are trying to figure out how can I have access to this treatment option and not break the law. So we have hemp-derived CBD, which was descheduled under the 2018 Farm Bill, and that is no more than 0.3% THC by dry weight. Currently, it's important to know that there are very few regulations out there. FDA, the federal drug or the Food and Drug Administration, does have jurisdiction over CBD. However, they're still in the process of figuring out the regulations for it. So, you know, when you think about going to like CVS and picking up a dietary supplement, you do that knowing that there are some kind of regulations around the manufacturing and processing of that. And right now, that is just not the same for hemp-derived CBD that you can maybe go online. Like Dr. Patel said, you can go on Amazon. Those don't fall under the same strict regulations. So you need to be very careful and be aware that there are bad actors out there. You know, again, the California study that was mentioned that found that there were substances in the oil that weren't reported. So this is just important for you to know that just because you can buy it online doesn't mean it's necessarily very well regulated. And there are unfortunately some bad actors out there. So just be aware of that. And then we also have cannabis-derived CBD, which will mostly be found in state dispensaries under the state law. So this will generally have more than 0.3% THC by dry weight. Again, this is probably found in dispensaries because of how they have to operate under state law. With anything that you get from a dispensary that may not be classified as hemp-derived CBD because of the dry weight THC levels, it's important for you to know that as soon as you leave the state with the product, that's when federal law applies, and that would be a violation of state law. And then also, as Dr. Patel mentioned, each state regulates their medical and recreational programs differently. And so, you know, it's really important to do your due diligence and find out how carefully the state monitors the manufacturing and cultivation process to really make sure that you're getting a quality product and you're getting what you think you're buying. And one note, this does not apply to Epidiolex. Epidiolex went through the FDA approval process, and so it is classified as a pharmaceutical medication. So if you or someone you know is prescribed Epidiolex, it doesn't fall under this framework that I'm talking about today because it falls under the regular, medication framework. So just think of it like Keppra or Onfi or other pharmaceuticals, and don't worry about the implications that all of this necessarily have on Epidiolex. So the FDA has formed a cannabis working group, and they are working on coming up with regulations to make sure that the products that are out there that you can buy as consumers are what they say they are, and that you're not being lied to or duped, or you're not buying anything fake. The FDA has solicited public comments for this, which the Epilepsy Foundation did submit. They also held a public hearing and talked to stakeholders. The Epilepsy Foundation has been involved in that as well. There are other ways that federal law can also apply. So you won't hear physicians talking about prescribing medical cannabis under state medical cannabis laws because that is still illegal under federal law, which is why a lot of people use the terms recommended. So while, it is treated a little differently as far as the law goes on the medical side, you still need to keep your physician as updated as possible. This isn't something that you should feel like you should hide or worry about the legal implications in speaking to your physician, because it is critical that just like any other treatment decision that they're involved and kept up to date. The foundation also supports a number of bills that would seek on the federal side to fix this problem a little more. One of them is one that Freeman advocated on when he came to our Teen Speak Up Public Policy Institute. It's the Strengthening the 10th Amendment Through Entrusting States Act. And what this would do, it would codify in federal law that as long as you are following the laws in your state, you absolutely cannot be prosecuted by the federal government. And it's allowing the states to decide what kind of program they set up themselves. This is not a perfect solution to our problem, but it would go a long way in safe, legal, and meaningful access to medical cannabis and CBD. And then again, just talking about the Farm Bill a little more. After the Farm Bill, there was a boom in CBD. You can find it anywhere. I was just at Walgreens the other day, and they had a whole sort of CBD section set up. There are topical ointments, there's oil, there are patches. There is just a lot out there, and it's sort of the Wild West of the cannabis policy field. So even though hemp was reclassified, it's important to know that this is not a free-for-all. So what I mentioned earlier, the FDA is still tasked with regulating hemp-derived CBD products, and that decision is forthcoming. We are expecting it soon, and this will sort of change what products are on the market, the requirements that are on them to make sure that sort of from seed to sale, it's safe for consumers, and that they aren't lying about anything, truth in labeling, testing. So that's something that we are monitoring going forward. And then again, it's important for you to be a smart consumer. Work with your healthcare team and do your research on hemp-derived CBD products to make sure that you're getting something that is trustworthy and that you can use. And then another thing that the foundation is also working on is medical research. As I mentioned earlier, because cannabis is a Schedule I substance, this means that doing medical research on it is very hard because the federal government has already decided that there is no acceptable medical use for it. Current regulations also limit the kind of cannabis researchers can use and require them to obtain permission from the Drug Enforcement Agency and the Food and Drug Administration, which can take a lot of time, and it can also be very costly. And quite frankly, the cannabis that they are allowed to use for research is not the same kind of cannabis that you would get from a dispensary. So there are a lot of hurdles there. It's very burdensome and expensive for researchers. So another bill that the Epilepsy Foundation does endorse, and we advocate its passage, is the Expanding Cannabis Research and Information Act, which would reclassify cannabis, and it would open up these barriers a little bit and make it a little easier for researchers to get their hands on the cannabis needed to do the kind of research that is needed for us to get more answers on why CBD or medical cannabis works, who it may work for best, all the kinds of information you think that you want to know when you're starting any kind of treatment option. So that is one of our hopes, is that we can make medical research a little easier so we can get more answers as well. And finally, we do have a few ways that you can get involved. First, you can visit our website at advocacy.epilepsy.com. You can learn more about medical cannabis, specifically on our medical cannabis page. You can learn about the other issues that we advocate for as well. And you can sign up for our Speak Up, Speak Out advocacy network and become an epilepsy advocate, and you will receive action alerts and other kind of notifications on what is going on in the world of epilepsy policy and how you can get involved for advocating for yourself, your loved ones, and the 3.4 million people living with epilepsy and seizures in America. And if you have a story about how medical cannabis or CBD has positively impacted your life or someone's life or a loved one's life, then please reach out to us at publicpolicy@efa.org to share your story. We are always looking for personal stories that we can then share with lawmakers to really put a face to this issue and let them know that this is a real issue for the epilepsy community and one we care about, and one that is prevalent in their state. And your stories also, we really appreciate them, and that is an easy way for you to get involved. So please do reach out if you have one. And I think that's it for me, John.
Thank you so much, Abby. I hope some of our attendees will definitely sign up to get involved in our advocacy efforts. So now we are going to have all of our speakers on stage, and we're going to do a brief Q&A. We have one question for each. Thank you to those of you who have put them into the chat session. And I will have to say, before we get started, I want to share that Abby is not able to answer any specific legal questions and won't give individual guidance regarding this topic. Okay, so let's get going with the first question. And this one is for Dr. Patel. Epidiolex, of course, right now is only FDA approved for 3 different types of seizures, syndromes. What about those who may have refractory epilepsy or really difficult to control seizures? Is there any hope for the FDA covering those types of seizures as well? And what should a person do about that?
Yeah, that's a really great question. So many of the treatments we use specifically in pediatric epilepsy may or may not be FDA approved, but still can be prescribed as long as insurances are authorizing them. And if you look at the labeling for the FDA, what I recommend, because we've done and had some success publishing data on looking at different epilepsy syndromes outside of the label, and those articles have been very useful to help insurance companies authorize it or at least pay for it. The other thing is remember the label is seizures associated with Lennox-Gastaut syndrome, Dravet syndrome, and tuberous sclerosis. Well, many of the folks who have epilepsy outside those 3 specific syndromes have the same or similar seizure type. So we've utilized that as well. So I'm not sure if there's going to be any pursuing of FDA labeling that will expand outside those diseases, but it still may not be that still may not be a barrier to you getting the medication if you have treatment-resistant epilepsy. So just work with your medical provider, and sometimes they can provide letters to support this from their insurance companies that cite some of these studies and talk about some of the other chances of success. And remember, like I said, we've published this, so it's not like I'm not just speaking to you based on my experiences, but I'm also being able to speak to you from medical literature. So that expanded access trial I highlighted at the beginning, remember, 20-ish% or whatever had Lennox-Gastaut and then also Dravet, but that meant there's a lot of people who didn't have any of those things, and we saw the same benefit. We're not seeing differences as far as that goes. So, there are people who have convulsive seizures that can respond. So it's just important to have that conversation with your medical provider. So really great question.
Okay, great. Thank you very much. And this next question is for Abby. This comes from our chat, Abby. And for those who may operate heavy machinery and who are regularly drug tested at work, but also use cannabis for epilepsy, what can you say to them as far as their protection? Could they get in trouble? What's your viewpoint there?
This is another a complicated question because of the federal and the state laws that I was talking about in the presentation. It's hard because they say two different things. So I'll start with very few states in their medical cannabis program provide concrete protections for individuals who are using medical cannabis under the law. So unfortunately, this does mean that we have seen individuals be drug tested at their job and lose their job because of that. And there's one answer under state law. It's depending on what the medical cannabis law of the state says, if there are any protections that it gives. But if it's any kind of job that requires a federal license or falls under federal regulations of some kind, for instance, if you're working for like a telecommunications company, even as like a in-state technician for them, they can fire you for using medical cannabis, even if you're doing it 100% under the color of the state law. And so unfortunately, this is yet another area where we have a lot of work to do, because as with any other treatment option, if you are properly using medical cannabis to treat your epilepsy and your seizures, then you shouldn't have to worry about also losing your job. So this is something that I spend a lot of time thinking about. I know our legal director has thought about it as well. And it is something, when we look at medical cannabis laws, and when we also look at federal fixes here in Washington, D.C., that's something that we think of. As with any other treatment option, you should have the ability to explore it to control your seizures without worry about losing your livelihood. So unfortunately, I don't have a concrete answer for you other than you hit the nail on the head with yet another complicated issue within this policy area, and it's definitely something that we're looking at and hoping to fix.
All right, great. Thank you very much for your insight. And our final question to Leanna and Freeman. I'm just curious, and I've been able to witness the TSU program over the years. It's a remarkable program for both teens and parents who are able to attend. What is your favorite part about going there and being with other families and doing the work that you do?
In my opinion, it was definitely Capitol Hill Day, because you work up to get to that point to where you're actually confident to speak with them, and you work on like what points to address and just stuff like that, and it makes you feel really good once you just like actually get out there. So
Perfect. Leanna, any comment from you too?
I had two comments. I had a comment about the TSU that he was just, I think, sharing his story with big legislators that make a difference was very nerve-wracking, but the education that the kids got leading up to it with their conferences and their meetings was really inspiring for the kids, and it gave them that voice and confidence to go and speak with people that hopefully listen to what they have to say. So it was a great opportunity for our family. And just before we run out of time, Abby, I wanted to comment on the question that you had about the drug testing. We've run into problems with that with Freeman, because he does have a prescription with his neurologist and with our dispensary. And he participates in high school sports and middle school sports, and they have to go through drug testing as part of being an athlete in the program. And so we had to define and kind of put out there that he was taking medical CBD, and it's on his school file. So he's been pulled for drug testing twice, and he's tested positive twice. He goes down as a negative for the district, but had we have not provided a written prescription, backing from everybody around us that he's legal to have it, he would have gotten probably expelled from school. So we're doing our part right now to try to work with our district to make it an easier process for any other kiddo, because surely he won't be the first one in our school district.
Oh, yeah.
And they won't even give it to him at school. So that's another fight we're dealing with. But so we're doing a lot of stuff on our end to rectify that. But it was just I wanted to add to what you were saying, because, he could, if we weren't fighting for him, he could be kicked off cross country teams and expelled. And so we've had to do our part to make sure that he can continue to take the medication that works for him, all the while not getting in trouble for it. So.
Yeah, and thank you for doing that. Families definitely lead the areas of advocacy in many situations, and so that's how it gets done. So thank you so much for doing that. All right, well, this is going to close out our session, and thank you for all the questions we received in the chat box. And again, thank you very much to our speakers for being here today. And don't forget, you can connect with others in the community by clicking on the attendee tab. Also, please make sure to answer our epilepsy treatment poll questions, which you can find in the link above the live video. Choose the one answer for each question that is most applicable to you. And again, thank you to SK Life Science for sponsoring our poll. Okay, now it's time for our final session, getting involved and making change. During this session, we'll learn about how to get involved in your community and make change. I'll tell you a bit about the Kids Group program. We'll learn about Seizure Safe Schools and the Epilepsy Foundation's advocacy team and volunteers from Brit. And Miles will share about his journey and how he's getting involved in his community. And with the other sessions, it will be followed with Q&A, so please submit your questions using the chat during the session. Well, if you've been with us today, you already know that my name is John Scheinman. I'm the Director of Youth Programs at the Epilepsy Foundation. I live in Clearwater, Florida, with my wife, Allison, and 15-year-old twin daughters, Haley and Olivia, otherwise known as Livy. Livy is the inspiration for Lemonade for Livy, and she lives with very difficult to control epilepsy. Her health challenges are what transformed me into an advocate and brought me to the foundation. I currently manage the Kids Group program, and I'm working to grow participation while helping members and their families make an impact no matter where they live. I am committed to supporting this community, and I always believe that kids, regardless of how old they are, can change the world. Okay, so let's get into what the Kids Crew is all about. The program has over 3,000 members in the US and participating digitally around the world. It's really been an amazing experience to see these kids, to get involved and to have them be empowered to give back in their communities. This program is open to all kids who are 14 and under, with or without epilepsy. They do not need to have epilepsy to be in this program. We have many siblings. We have many kids who have their parents with epilepsy or a friend, and this is regardless of ability. We have many kids who need a little bit of extra help, either from their parent or from a sibling, to participate, and we encourage and welcome that. When kids register for the program, they receive a membership kit that comes with a lanyard and a certificate and a name tag and a name badge. They get updates and announcement emails, and they also receive a printed newsletter every 3 months, which comes with amazing stories about the kids and what they're doing in their communities. It has information about epilepsy so kids can learn more and have the ability to teach others. And it comes with updates about what great things are happening in the program. Kids also have the ability, once they're members, to sign up for our online group page where they can interact with other members if they want to. As I said, this is an empowerment program. This is not just one where they learn. We actively encourage them to get out there in their communities and to make a difference and to create change. And when they do that, they get to earn themed pins. And we have a number of members who are out there and earning their pins on a regular basis. And one of the best parts about this program is that it's free to join. And so there are certain goals and objectives with this program. The big goal, of course, is to empower kids, to eliminate stigma, and to foster acceptance for all people with epilepsy and their families. Kids have a really unique way of getting out there in their communities and motivating others to join them in their efforts. And these kids are leading the way in this area. Now, some of our objectives are: we offer a welcoming and safe environment. As I said before, the Kids Crew is open to all kids 14 and under, regardless of their condition, or regardless of if they are just a typical kid with no health issues. We want all of these kids to get involved and to learn and to make a difference. We, of course, want to help members see that they are not alone in their journey. So many kids and so many stories that we have heard are that kids, when they are diagnosed, feel like they are the only ones with epilepsy. And that is certainly not the case. And we really want to make sure that kids know that. And we present opportunities for meaningful participation in their local communities. They don't have to be at a place where there is a big walk. They can walk around their neighborhoods and participate virtually. We want to make sure this is accessible to all kids around the country. And we teach kids to give back. The power of giving back is so strong. And when kids do that, they get to see the impact that they have on others. It improves their self-confidence, it improves their own lives, and it really improves their community. And another part of the program, which we're just starting now, is to identify future leaders and to foster their skill set. The Kids Crew is going to be launching a leadership council in the near future where we have a handful of kids who really want to participate in how the program proceeds forward. We want them to be involved and to have their input so they can tell us what they want, because they know the best. Okay. And here are all of the themed pins that our members can earn. So much about epilepsy is around creating and spreading awareness. And so we ask kids to do that in their communities and to spread it with the help of their families, either online, socially, or wherever they feel that they can reach people. These kids are educating others in their community once they learn more about epilepsy and seizures. For International Epilepsy Day this past February, we had Kids Crew members educating over 1,000 of their peers and their classmates. And so when so many kids come together and work as one, they can really make a terrific difference in their communities. And of course, we want them to advocate for change. As Freeman did, he's a member of TSU. When he gets to be a certain age, you can join that program. And so we want kids to start early and write letters to legislators. They can, of course, go and see them locally. And if they have the chance, they can go and see them nationally. But they can do this virtually, too. Of course, with COVID-19, a lot of things have been moved online. And we have kids who are reaching out to the legislators and telling them about the important bills that need to be passed and the support that the community needs. Then we have Act of Kindness, which is helping somebody with epilepsy or someone who is taking care of epilepsy. Kindness is such a big part of kids' lives, and we really want to make sure that they know that being kind to others is important. Then we have Lemonade for Livy, which is holding a lemonade-themed event Typically, it's done, of course, out in the public where they can hold lemonade stands and other events. This year, again, and most of it has been virtual, but we have a lot of great participation from kids. The Kids Crews have raised tens of thousands of dollars for the programs at the foundation. Of course, the Kids Crew program being one of them. But they really get to learn that with their efforts, they can help others and make a difference this way. The Purple Pumpkin Project pin, of course, is a fun way to spread awareness in the fall, where kids get to paint their pumpkins, and when people ask why their pumpkin is purple, kids get to tell them about epilepsy and what their story is. Our Walked Together pin, which is around either attending a walk in person or virtually, and getting to be with the community and knowing that the kids are not alone, but that they're also making a difference for others. We have our Athletes versus Epilepsy themed pin, which is around a 10-day challenge of health and fitness. It gets kids to see that if they can make some good, healthy choices, that can impact their lives in a number of different ways. And finally, when kids earn all 8 pins in one calendar year, they get the World Changer Award, which is a big deal because these kids work really hard to do all of these things. And so we want to make sure that we give them the recognition that they deserve. Okay. And you can see here, these are some of the images from the events that the kids can participate in when they become members. Before all of the health issues around the country, many groups of kids were meeting locally to either do bowling events or do their purple pumpkin painting events. But we had to move many of those online. And so we were able to shift quickly and create virtual events. We started holding virtual bingo events. We had a Kids Crew talent show, which was amazing to see some of the great talent within the Kids Crew itself. We held an end of school year luau. So many kids didn't get to have a celebration at the end of school because they were forced to be at home and be doing school virtually. So we tried to create a really fun event for them where they could dress up in island attire. They could decorate their rooms. We had entertainment that was straight from Hawaii. And it was just a really fun time to get the kids together and so they could share in a little bit of celebration. And finally, we do have periodic Kids Crew meetings for those who want to join. They get to meet other kids who have epilepsy. Many have never met someone else in their community like they are who has epilepsy. And so we attempt to bring the kids together so they can share their experiences, but so they can really find out what other kids are doing. What's a seizure like for that person? Or if it's a sibling, many siblings haven't talked to other siblings, and so they get to ask questions too. So it's just a really great way to bring the kids together in a safe environment where they feel like they're valued. And these kids, honestly, these kids have stolen my heart. I get to see some of these amazing stories online. I get to see what the parents send back to me through emails and saying that my child associates with this program, and it's really giving them confidence, and it's just allowing them to look at the world a little bit differently because they know that there are other kids out there who are just like them. And so it's a really rewarding experience, and I'm so thrilled that there are so many members who are involved and who are continuing to do great things in their communities. And it really is true. Kids can change the world. There is no question. And every time I see somebody completing an activity or earning a pin, it's just reinforced even more. So I'm so excited to see what the Kids Crew does in the coming days. And so how do you register your child for the Kids Crew? It's a really simple process. And of course, the parent has to do it. It's a really quick form with a handful of questions. It's available on epilepsy.com/kids-crew. And I hope that you will go on to the site, check it out, and see what the Kids Crew is all about. And I hope that your kids will become members too and join something that's bigger than all of us, that's really trying to change the world. Okay, so that does it for me with the Kids Crew. And of course, if there are any questions, you can put them in the chat box, or you can ask during our Q&A session. And now I'm excited to welcome our next speaker, Britt Dorfman, who is the Government Relations and Grassroots Associate at the Epilepsy Foundation. She manages grassroots activation, cultivation, and engagement. She develops advocacy-related communications and manages the planning of the Teen Speak Up and Public Policy Institute Conference. So thanks for being here, Britt. Welcome.
Thank you so much for having me, John. I'm so excited to be here to talk to you all about getting involved and making change from an advocacy perspective. All right, let's see. Slides. Before we get started, I just want to talk a little bit about what the foundation advocates on behalf of. I'm having some technical difficulties. Nope. Sorry, folks. There we go. So sorry. I'm missing a couple of slides here, so please excuse me for a second. Can we go to the next slide? Is that possible? All right. Here we go. So the Epilepsy Foundation advocates on behalf of people who are living with the epilepsies, their families, and caregivers to overcome the challenges of living with epilepsy and accelerate therapies to stop seizures, find cures, and save lives. Our top policy priorities include ensuring access to quality health care that is affordable, physician-directed, and patient-centered, securing funding for epilepsy programs, research, and treatments at the state level and federal institutions, safeguarding disability rights, and fostering biomedical innovation. But why is advocacy so important, and why should you get involved? Can we go to the next slide? So if you're not at the table, you're on the menu. And I want folks to think about that for a second. So why is advocacy so important? Next slide. The Foundation's programs, services, advocacy, and research initiatives have made significant progress, but there is still a lot of work that needs to be done at the local, state, and federal levels to continue to raise awareness about the epilepsies and advance public policies that affect the epilepsy community. Congress and state legislatures are constantly considering and putting in place policies that can affect the community. And you all already have the most important tool that you need to be successful advocates, and that's your story. Your story is so powerful, and sharing your story with elected officials is the best way to make sure that your needs, the needs of your loved ones, and those of the community are considered when lawmakers are making these important decisions. So think back. If you're not at the table, you're on the menu. You need to make sure your voice is heard. Without speaking up and telling your story, elected officials may never know what epilepsy is, what living with epilepsy is like, or even know that an issue is important to you. Next slide, please. So I'm going to talk about a few programs and initiatives that the Foundation has that allow folks to raise their voices and get involved I'm going to kick off with our Teen Speak Up and Public Policy Institute. And hopefully you all saw the last session, and I know John has spoken about it a little bit. And Freeman and Leanna, our TSU family from Central and South Texas, talked about it in a really awesome way. The Teen Speak Up program is my personal favorite. It's an honor and a privilege to get to work with these fantastic teens. They come from all across the country. They're nominated by their local Epilepsy Foundation office, and they get to come to Washington, D.C. to receive advocacy training, learn how to share their story, and go up on Capitol Hill to talk about important issues that affect the community. Next slide, please. It's not only a great opportunity for teens to go up on Capitol Hill, but it's a great opportunity for them to meet with other teens who are living with epilepsy. I can't tell you how many times I've walked into that room and they're so shy and awkward, but by the end of the program, they're fast friends, the best of friends with each other, and they honestly don't want to go home. It's an incredible thing to witness them being so open and sharing their stories, and know that they can be comfortable because the teens who are in that room with them have experienced some of the same things and overcome very similar challenges. It's a great opportunity for parents and our local Epilepsy Foundation staff to connect and network and learn about what's going on at the federal level, at the state level, and talk about new research and a lot of other initiatives that the foundation is working on. And we were super lucky. We were able to get in the 2020 Teen Speak Up conference before the pandemic shut many things down. We had 175 advocates from 38 states and 53 teams. We were able to have over 180 meetings on Capitol Hill with members of Congress and their staff. So we were able to make a huge impact and hopefully make a difference and share a lot of stories and really talk about the issues that affect the epilepsy community. When the program is over, the teens go back home and they take what they've learned and turn it into action in their local communities. And before I talk about our next initiative, I want to start and say that the next initiative, our Seizure Safe Schools, actually started as someone's year of service project. In 2016, Lindsay Crunk attended the Teen Speak Up with her local office, the Epilepsy Foundation of Kentuckiana. And when she went back home, she was concerned that her teachers didn't know seizure first aid. So she worked with her local office and she worked with her legislators to work on a bill that in 2018 was passed and signed into law, HB 147, the Lindsay Crunk Act, which was the first Seizure Smart Schools initiative passed anywhere. Next slide, please. Our Seizure Safe Schools nationwide initiative is legislation passed at the state level that requires training for school personnel, including nurses, teachers, and volunteers. It helps to safeguard physician-directed care and brings awareness to the entire educational community. We know that 3.4 million Americans are living with epilepsy, and 470,000 of them are children. And most of them are usually in school. And so I know for many parents, it's really critical to know that your child is safe at school. And I've heard from many of our TSU teens that the first time they ever experienced a seizure, that it was at school. And the response varies from either really great, they knew what to do, to not so great. We know that 1 in 10 people will have a seizure at some point in their life. So requiring training for school personnel is really critical. Making sure that students with epilepsy or any student who may experience a seizure or any school personnel who may even experience a seizure, that everyone knows what to do, and especially for students that they can feel safe and help reach their full academic potential. Next slide, please. So what is included in this legislation? There are 5 key components, and I've talked a little bit about them, but first and foremost, requiring school personnel to complete a seizure recognition and first aid training, mandating that seizure action plans are made available to anyone responsible for the student, ensuring that any FDA-approved medication prescribed to the student can be administered, educating and training students about epilepsy and first aid response. Just like so many students are CPR certified, we also really want students to know how to respond to a seizure and know what epilepsy is. And last but not least, a Good Samaritan clause. Next slide, please. To date, 5 states have already passed this legislation: Kentucky, Indiana, Illinois, Texas, and New Jersey. In this past legislative session, before COVID, shut down many things, we had 20 bills introduced, which was really, really great. But passing a piece of legislation at the state or federal level is a process. It requires collaboration, flexibility, persistence, patience, time, and understanding of different perspectives. We are incredibly lucky we get to work with engaged and passionate grassroots advocates, many of whom are our TSU families, but many of which are just families, I'm sure like many of yourselves, who have heard about this initiative and wanted to get involved because it's an issue close to your heart. Collaboration between the local Epilepsy Foundation office, our grassroots advocates, and us here at the national headquarters is really crucial to make sure that we can get this legislation passed and make sure it's as strong as possible. We do anticipate many bills will also be introduced in the 2021 legislative session, but just be aware that due to the pandemic, it's possible that the types of legislation that's passed may be limited, but we are incredibly hopeful. And if you are interested in getting involved in passing seizure safe schools legislation in your state, please don't hesitate to reach out to your local Epilepsy Foundation office or to us here at National, and I'll talk about how to do that towards the end of our presentation. Next slide, please. Well, I'm really excited to introduce, and for everyone who's watching, you're getting a super sneak peek at our new Epilepsy Advocacy Champion program that will be launched hopefully in just a couple of weeks. We're aiming for September. This will be trained high level, so there'll be grass tops advocacy volunteers who will help us build those strong relationships with their members of Congress and state legislators by sharing their story and talking about how certain issues are important to them and their loved ones. They're going to serve as an integral role by connecting and hopefully recruiting other grassroots advocates in their state so that we can amplify the message of the epilepsy community. Next slide, please. The Epilepsy Advocacy Champion program is geared toward those who are 18 and older, who are those who are living with epilepsy or those who have a connection to epilepsy. And we hope that it'll be a great opportunity for folks to learn about the legislative process and learn about the issues that are affecting the epilepsy community. We're looking for passionate and engaged advocates, and no government relations or policy experience is necessary. Just a true willingness to share your story and get involved. And we're hoping that many will be eligible to attend an advocacy conference in Washington, D.C., so that they can go up on Capitol Hill and share their stories with legislators and advocate for policy priorities. Next slide, please. I just want to end with one of my favorite quotes that will hopefully inspire many of you to want to get involved. Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has. Next slide. So I've talked about a lot of different programs that we have at the foundation. So if you want to get involved, please visit advocacy.epilepsy.com to learn more and take action. You can sign up to become an epilepsy advocate by going to bit.ly/SUSOEFA. This will allow you to receive state and federal targeted alerts so that you can take action with just a few clicks of a button. And you'll also receive our monthly advocacy newsletter, which will keep you up to date on important policies that are affecting the community. We don't bombard you with emails, I swear. So we just hope that you sign up to become an advocate. And if you are interested in getting involved or have any questions, please feel free to contact us at publicpolicy@efa.org. Thank you.
Thank you, Britt, for educating us all on the exciting work the advocacy team does and how to get involved. Our next speaker, Miles Levin, is a filmmaker with epilepsy whose current mission is to fight stigma using cinema. By making epilepsy-related film, Miles believes that our community can mirror other diverse groups who have fought for their place in mainstream conversation, using cinema to reach general audiences. Miles's film, Under the Lights, can be followed on social media at Under the Lights Film and his website, underthelightsfilm.com. Welcome, Miles.
Hello. Hi, I'm really grateful and excited to be here. So I'd like to begin by introducing myself. My name is Miles, and I am a filmmaker. I'm an epilepsy advocate, and I've had epilepsy for some 21 years now. I'm 25. My epilepsy is drug resistant. I've tried just about everything under the sun, and here I am. So I'm here to talk a little bit about how I've gotten involved in the community and how I've sort of found my place and my means of being useful. And then I want to sort of break that down into basic principles and see if maybe together we can find ways for each other to sort of find your own perfect ingredients for getting involved and why that's important. So Under the Lights is a short film I made, and we're going to play a short video, which I think is probably the best way to explain what exactly it is we're doing. And then I'll tell you a little bit more about it. So could we start with the video, please?
Hi, my name is Miles Levine. I'm the writer and director of Under the Lights. Under the Lights is a short film about a character named Sam who has epilepsy, and he's so desperate to feel like a regular kid that he goes to prom knowing the lights will make him have a seizure. We cast 2 incredible Disney Channel stars. We had Emmy-winning producers. This was not an easy film to make. We built our set, a bathroom that fit all the dimensions that we needed and that took months to build. We set up a prom scene that took 2 full days just to put the decorations together. We had a crew of 20 people from Los Angeles, from Sonoma County, who said, I don't care how far I have to drive or how long it's gonna take, I wanna be a part of this.
I was just really taken aback by sort of how original it was, how sweet and genuine and authentic it was. I was so uneducated about epilepsy. I just started becoming so much more curious. It was one of the best experiences I've ever had.
I was blown away. I hope the film brings an ordinariness to an extraordinary situation. I want the film to help the general population understand.
I had so much fun. I don't know what it was. I didn't have any seizures while I was on set, and these days were long. We're gonna start an interest in talking about a demographic that does not get seen on the silver screen. And we want to fight stigma with cinema. And I think we're off to a good start.
So that's a little bit about my short film, and the birth of this project was that I have been involved with the Epilepsy Foundation of Northern California for many, many years. I worked at a camp for kids with epilepsy, which is one of the most transformative things I've ever done. And I did so for about 7 years. And it struck me that on the first day of camp, kids would often come up to me and express that they'd never met anyone with epilepsy before, or at least, of course, we know 1 in 26 people do, so they didn't think they've met anyone with epilepsy before. And they also would introduce themselves by first stating that they had epilepsy and then stating their name, that it was more important to let me know first, I need you to know that I have epilepsy, Miles. By the way, my name is blank. And that was kind of chilling to me. I also noticed that at awareness events, as many as there are and as important as they are, largely the people who show up to these events are people who have epilepsy or who know someone who has epilepsies. These are already people who care. And they're there for more information, and sure, they're there to support. But if we're going to change anything, we need to eliminate the stigma that's associated with epilepsy. And in order to do that, we have to somehow bring people into the room who know nothing about us and who have no previous interest in knowing anything about us, because those are the people who, frankly, I think make life a lot more difficult than the epilepsy alone. So I thought, well, what can we do about this? The next thing that struck me was that we've seen other minorities, other diverse groups have enormous success fighting and tearing down stigma using cinema. That independent film is this really rare space in our culture where people leave their homes, pay money, go out of their way to see and hear from groups that they know nothing about. People are sick of seeing the same movies over and over and over by the same groups of people. People want to hear a new kind of story. People want to see a new kind of voice heard. And furthermore, arts groups are have bigger initiatives than ever to support and hear from those voices. At an independent film festival, people are most likely to attend when there's a Q&A and they can hear from the filmmaker. So what an enormous opportunity to spread epilepsy awareness, because I figured if we could get public general audiences to hear from us, to see an authentic and empathetic representation of epilepsy, it replaces any previous fearful point of reference. If you have felt something for a person with epilepsy, whether they're fictional or not, you are far less likely to go back to your community and participate or contribute to stigma. So that was my initiative. The film stars, as I said, two Disney Channel stars who had no previous connection to epilepsy, but put in enormous research, embedded themselves in our community, spoke with doctors and parents, and worked with me extensively to make sure that they got it right. And they really knocked it out of the park. And as a result, a few things have happened. One is that film festivals around the country are reaching out asking to see the film. And we've won awards at an Oscar qualifying film festival, and recently received an audience award, which means the highest rated film at the film festival, at another film festival. And as the news spreads, the events that want to see the film become more and more prestigious, which means that we face a larger and larger opportunity for conversation. And the goal here is to prove that this works. Because I figure if we prove that this works, then we can scale it up and we can make the feature film and cast even more stars, which guarantees that we have an opportunity to have a mainstream conversation on this subject, which is deeply important to me. One of the most amazing things that's happened as a result of making this film is at private screenings with limited amounts of people, because the film is not available yet. It's purely at film festivals and private screenings. We've had people say, I saw this film and I decided for the first time to talk with my family about my epilepsy. I saw this film and I decided to see a physician. I heard from a festival programmer that an audience member used the film in order to have an icebreaker to speak with their unsupportive family. The power of seeing yourself on screen, represented as you are, has the power to make social change, or at least open the door for us to use our voices. My goal here was to make a tool that would be useful to the epilepsy community to use as you see fit. So quickly, before I move on, I want to let people know, if you are interested in the film, if you want to see the film when it comes out, please go to underthelightsfilm.com and subscribe with your email so that you can join our community, because we need allies. All these goals that I'm saying really don't happen unless people come forward and want to join in. The next goal is to make the feature-length film and to really go into the major leagues, so to speak. So if you're interested in discussing that with me, please email me or go to the website, find me on social media under the Lights Film. Moving on. The making of this film was was my means of getting involved. On the subject of getting involved, I found power to speak on epilepsy by taking something that I was interested in and pairing it with epilepsy awareness, trying to use what skills I have to be useful to something greater than myself. When asked if I would speak on the subject of getting involved, what came to mind immediately was that earlier story that I told about the kids who would introduce themselves by saying they had epilepsy and then by sharing their names. And the reason that was so chilling to me was that the self-story or identity is really, I believe, the first step in making sure that we're heard and starting to make a change in our social circumstance where people with epilepsy are treated so poorly. We can't hope to move forward if we can't find the strength to do so. I, in my high school years, had a really, really hard time, and I was bullied a whole lot, and I was pretty miserable. And the big moment that changed everything for me was when I discovered that I enjoyed filmmaking. And suddenly the hierarchy of how I would introduce myself changed. Whereas before it was, hi, I'm Miles, and I have epilepsy. Epilepsy being the secondary trait and how I felt it was best to describe who the heck I am. Filmmaking eventually replaced that as that spot in the hierarchy. Hi, my name is Miles Levine. I'm a filmmaker and I have epilepsy. And in my senior year of high school, that had an enormous impact for me because I had a new sense of self. And suddenly, epilepsy was no longer the thing that I thought about all day long. It was filmmaking. Cultivating an interest, a passion, has an enormous impact on how you see yourself, raising self-esteem, finding ways to feel good about yourself is incredibly important. And not everyone has that opportunity. Not everyone is sort of struck by lightning, that they know what it is that they want to do for the rest of their life. I got very, very lucky. But I think that the key really is to sit down and first consider who you are before you decide how you can get involved. So I want to share the following steps as to how this worked for me. And if you decide this is useful to you, then go ahead. But this is strictly from my own experience. What do you enjoy? Are you a good cook? Do you enjoy working with animals? Do you enjoy gardening? Are you a good listener? Do you enjoy sports? Consider the things that you're good at or that you are interested in exploring. And if you're not sure what you're good at just yet, then you need to start with that step of exploring. Look around, read articles, use meetup.com, which is for a huge database of hobbies and people who do them. And search around and consider what it is you might like to pursue. This is cultivating a new identity beyond epilepsy, something to step away from your experience with epilepsy, to think about, to feel good about. Once you think you have that, Ask yourself if there are communities you can get involved in or communities you can create. These could be hobby groups. They could be friends that like doing stuff on the weekends. And if you don't have those things, the internet is actually, it turns out, not a bad place to start. Start with Facebook groups. See what's happening in your community. The next thing I would consider is, since epilepsy is a part of our identity, that can also be a great place to start. You've heard over and over and over again during this pipeline conference ways that you can get involved with the Epilepsy Foundation. And that's something that I did starting around the time I was in high school. I started working at the epilepsy camp, Camp Coelho in the Northern California chapter. And in doing so, I discovered that one thing I enjoyed that I didn't know that I would enjoy, in fact, I was actually adverse to participating in epilepsy-related events prior to trying the epilepsy camp, that I enjoyed being an epilepsy advocate. I enjoyed using my voice. And suddenly, when that happened, my hierarchy changed again. I was Miles Levine, I'm a filmmaker, I'm an epilepsy advocate, and I have epilepsy. And epilepsy fell to position number 4. So joining epilepsy-related groups, even if it seems like maybe you're not sure about it, you're on the fence, maybe you don't want to talk so much about your epilepsy, or you might not be there yet, consider it, because the epilepsy community does understand, which makes it a fantastic place to start. And they have plenty of ways that you can offer value. I have a book here, that I've been reading, it's called The Power of Meaning, and it's about the tenets of what make a meaningful life. And what people who talk about this subject all the time reference is that a meaningful life is about being something bigger than yourself. It's about finding a way to define yourself in terms of an other, in terms of a community or the kind of value you can provide. And that's why I asked, what are you good at? What communities are you a part of? Can you get involved? Once you figure out and you can name what value you have to offer that is useful to others, that is useful to something greater than yourself, the struggle with epilepsy begins to change. And once we can start to introduce ourselves in a different fashion, hi, my name is so-and-so. I enjoy this, I'm involved in this, and I also have epilepsy. Suddenly we project the confidence that makes it easy for those who don't have epilepsy to define us the way we want to be defined. It's not necessarily easy. It doesn't happen at the drop of a hat, but as soon as you're willing to open yourself to making that, beginning to try that exploration, it really can be life-changing. At least it was for me. And speaking of getting involved, if you want to be involved in the pursuit that works for me, at least, which is filmmaking and epilepsy through art, please reach out. I'd love to talk about it. I'm very easy to reach, and I like to be useful. So I'd like to open it up for questions, if I may.
Thank you, Miles, for sharing your story and your video with all of us. Sometimes it just takes a little bit of hope and inspiration to get people motivated to be involved. So really, thank you for the words of wisdom. And I think that really hits home with so many of us in the community. So now we have both Britt and Miles on the stage here for our brief Q&A. Thank you for some of the questions that you have submitted in the chat. And so I'm going to start with Britt. Britt, what is the age range for the new advocacy champions?
That's a great question. So the Advocacy Champion program is for anyone 18 and up. I don't think we're capping that, but just keep in mind there will be some commitments and requirements. And we'll be sending more information about the program soon. So if you haven't signed up for our Speak Up, Speak Out advocacy network, I would definitely encourage folks to do so, so you can be the first to know and get access to all the things that the program has to offer. And I also want to add for the Teen Speak Up, just in case anyone was curious about the age range for that, it is geared toward 13 to 18-year-olds, though we do have a little bit of leeway. We like to think that they graduate from Kids Crew into Teen Speak Up, and then hopefully into the Advocacy Champion program. I'm just gonna keep you all as advocates for the rest of your lives.
Thanks, Britt. And Miles, if you need any extras or any kid-aged actors or actresses, I'm sure I could find you some from the Kids Crew.
That sounds excellent.
And so, Miles, question for you too. You're really great. You gave some great tips for people who may not think they have a talent to use to get involved. Right? Everyone's got a talent to do something and to make a difference. And so I'm curious, once they find that, in your opinion, what can they do or what should they do to get other people motivated to get involved for what they're doing?
I think the best thing that you can do for your community, if you think you've found your thing, is to practice it, and not to practice it in the dark. For example, I would love it if everyone in the world saw this film. The truth is that that's not how it works, right? And so I like to talk about it, not just to promote it, but I want to sort of make a display and show that I experienced a transformation, and that I want others to know. I want others to experience this. If you're good at something, people are always very self-conscious about their talents. Try your best to be public with it. Share your good news. Show people that you're good at something and that you enjoy doing it. Once you start to do that, other people immediately they feel it and they get excited, and suddenly it starts to become sort of subtly more socially acceptable for people around you to start doing the same. And as people with epilepsy, I think it's especially important for us to share and talk about the things we're good at. Because everyone has that thing, whether we've discovered it or not. So.
Totally agree with you, 100%. And Britt, with Teens Speak Up, you mentioned the year of service. Can you talk a little bit more about what's involved with the year of service?
Sure, of course. Once the teens go back home, we encourage them to work really collaboratively with their local office. And if they come from an area that doesn't have a local office, they work with us at the national office directly. And we have 4 overarching goals. So one is definitely collaboration with the local office. Make sure people are meeting, making sure that the teens and their families know what's going on, what the local office is working on, what we're working on at the national office. So there's a free exchange of information so that if there is something that's going on, if the office is having a walk and we want the teens to get involved and share their story at the walk, either it's in person or virtual, we want to make sure that that information is out there. Second, we want them to continue to build their relationships with their elected officials at the state and federal level. They've already done it in Washington, D.C., and they can still do it from their home. And actually, our teens right now are having August recess meetings with in-district staff and D.C. policy staff. Being virtual, you can basically do it from anywhere. So we highly encourage them to continue those relationships, and we provide them with a lot of resources of, how to contact their state elected officials, federal officials. We provide some talking points. Luckily, a lot of the issues that they talked about when they're here in DC kind of continue, but there are always new issues that pop up, so we like to keep them motivated. One of the biggest goals that they have to do is putting on 2 to 3 awareness events, and that can be really anything that they envision. We want them to get creative. I've seen teens put on a purple day at their school. They've done things at a high school football game. They've done a training during lunchtime for all the kids who are eating lunch. People have painted, done a little gathering painting purple rocks. I mean, they've done Lemonade for Livy. They've done Purple Pumpkin Project, all of these really awesome things. So we encourage them to put on 2 to 3 of those so it can continue to raise awareness in their local communities and get other folks involved. And last but not least is to recruit other advocates in their area, which hopefully if they're putting on events, should be pretty easy to get other people wanting to get involved and wanting to be advocates. So we ask for a lot, but we hope that they take that experience from Washington, D.C. to heart and want to give back to their local communities and make sure they can reach other people. I've seen our teens do honestly incredible things, and I know it's truly empowering for some of them. So I love to see it. I think, like Miles is saying, it really helps people gain their voice and showcase why they're special and what they can offer the world.
Yeah, no question. I've seen the amazing impact the program has and what these teens have done, and so much of what they learn in the program they take with them to the next part of their lives. So it's a really great program. And so Miles, I'm gonna end the Q&A with you. If you can answer this question in just a minute or two. And so let's assume that the full length film is done and gets out there and is well received. What is next for you after that?
After the full length film? So
Yep.
Okay, so briefly, so the short film first will finish its festival run hopefully this year. We'll put it out. I want it to be useful to the epilepsy community. If you have ideas about how to get it out there, if it's useful in schools, so on and so forth, please let me know. The next thing is then to make the feature film, which should happen over the next maybe 1 or 2 years. Then I just want to keep doing it. I just want to keep raising the bar and taking it to higher and higher levels. Because people are responding. There are people without epilepsy sending us fan art every single day. The people who don't have epilepsy, kids. It sounds insane. The film's not even released, and there's kids saying, "I want to give a speech on epilepsy at my school." So there's a lot of potential here, and I'm really, really excited. By the way, go to the Instagram and check out the fan art. It'll melt your heart. But regardless, that's the plan. You got to let me get through the next 3 years first.
I'm very impatient, can't you tell?
Yeah.
Now, well, thank you very much for all you're doing to bring awareness to our cause and for everything else you're doing in the community. It's really, really appreciated.
Thanks.
And thank you for all of your questions, and thanks again to our speakers for being here today. If you would like to learn other ways to get involved with the Epilepsy Foundation, please visit epilepsy.com. And that closes out our last session and our first virtual community day. Thank you everyone for joining us today. I've loved being your moderator and hosting the event. I also want to thank our sponsors once again for all of their amazing supports. We covered a variety of topics today throughout the sessions, and we hope you learned a lot from all of our speakers. We hope you also took some time to connect with others using the attendees part of the platform, and you still have a little bit of time to connect by clicking on the attendee tab. The exhibit hall will be open until 4:30 p.m. today Eastern time, so you have just about 8 minutes left to go visit over 20 booths, so choose wisely. You can visit them, you can download resources from them, and you can also talk to some of the representatives who are there. I encourage you to take some time and explore the exhibit hall as best you can with the time left. All you've got to do is click on the exhibit hall tab. And again, thank you for spending time with us today, and please enjoy the rest of your weekend.